Let's go.
That's right here. Yeah, let me put this out the way. Joe, I've been running around. I ain't had time.
Hey. Ooh, that's loud. Hey, hey. 1, 2, 1, 2. Mic check. Yes, sir. You want to test this one too? Hey, hey, check, check. 1, 2. 1, 2, 1, 2. Check. Straight. Check one, check one. You good? I'm good for now, yeah, Heard. All right, let's see. Let me make sure I have all this. 311, 2, 2, 3. Okay. And open up all my morning slides. Doctor, you are ready to adjust as needed. This will be you, okay? So I'll let you work your magic.
I realize it makes more sense if I do the one that actually works first rather than the one that doesn't work first.
There you go. I think that makes a little more sense as well. Yeah.
Oh, man. Bam.
Cool.
We are good to go.
So we're just kind of hoping to match this volume on this microphone. Check, check, 1, 2, check, check, 1, 2. Hello, hello, welcome to CAGLA 2026, New Orleans, Louisiana. Check, check, 1, 2. Yeah, sounding much better now compared to, this is our first microphone for everyone to hear, and going to the handheld again. trying to match the volume, also, I mean, that's pretty good now. We just want to make sure everyone could hear and the live stream could pick up as well. But sounding much better. Thank you, Christopher, for the assistance. Check, check. 1, 2. Check. 1, 2, 3, 4. Talking from a comfortable distance, so I'm not too close from the microphone, about right here. I'd imagine a lot of people won't be necessarily right into the microphone, but about here. Yep, sounding good. 1, 2, 1, 2, 3, 4. And I imagine too, I mean, this looks easy for people who need to grab it and hand hold or whatever. But check, check. 1, 2. Thank you for coming. CAGLA 2026, New Orleans, Louisiana. Check, check. 1, 2, 3, 4. Check, 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 check. 1, 2, 3, 4, 5, 6, 7, 8. 1, 2, 3, 4. Check, check. Cool. Yeah, I think I'm good. Right, right. Great, thank you. I guess if you wouldn't mind, if you check the other, that's a good thought, I didn't think about that.
Encore, how can I help you? Let's have it closed this weekend, Sunday or tomorrow. We don't have any, the base size and our paperwork doesn't put a date. I'm on the floor. When I come upstairs, I'll take a look at it, check it out. All right, no problem.
right, we'll go ahead and get started. Thanks everyone for coming to our neuro-oncology block. We've got some really great lectures today. Our first one is from Dr. Michelle Miller. She is a neurosurgery resident at our Ochsner Tulane Neurosurgery Residency, and she is going to be presenting on her research on minimally invasive resection with brachytherapy versus SRS for brain metastases.
So as Dr. Golden said, I'm Michelle Miller. I'm a PGY4 in the Tulane Ochsner Neurosurgery Program. This work was done with Dr. Ware as our PI, and Dr. Keene was also one of the surgeons instrumental to this, who's going to be talking today as well. I'd also like to give a big thank you to Smriti. This is really a lot of her first author work, but she is one of our medical students at her match day today for neurosurgery, which is very exciting. And Zainab is actually also at her match day, so congratulations to both of them. I'm going to talk first about our paper, which was published a few months ago now, but that was a prospective trial looking at minimally invasive craniotomies with cesium brachytherapy. And then to try to address one of the main limitations of the paper, we went back and retrospectively matched that group to a standard of care SRS cohort. And I'll talk a little bit about the oncologic outcomes there, as well as some cost analysis. So, as everyone knows, metastatic brain tumors are very common. They affect up to 40% of cancer patients. For us as neurosurgeons, they're the most common tumor we see in adults. Standard of care for these, if they are large, which is typically defined as about 3 centimeters, does involve surgical resection followed by radiosurgery or whole brain radiotherapy. The goal at our institution is usually to get people in about 3 weeks post-op for their radiosurgery. Standard of care traditionally is kind of extended out to 6 weeks for that time window. And then, more and more these days, people are really pushing the number of metastases that are treated with radiosurgery as opposed to whole brain due to the cognitive side effects of whole brain. And then for larger resection cavities, hypofractionation is important to reduce the radiation necrosis risk. So, what are the limitations of that? Why even think about brachytherapy? Well, the main thing is there is clearly, it's a second visit down the road. There's a delay in therapy during which other lesions can keep growing. Sometimes you can have early recurrence or progression, and then some patients are inevitably going to be, unfortunately, lost to follow-up within that time frame. So brachytherapy is direct implantation of radioactive isotopes into the resection cavity with the assistance of our radiation oncologists at the time of surgery. Historically, there were trials with iodine-125, I believe at UCSF. They had good local control, but very high rates of radiation necrosis. And that has therefore been largely abandoned. Cesium-131, however, has a much shorter half-life of 9.7 days. So that allows for quick delivery of the therapeutic dose, but lower rates of radiation necrosis. In our study, we did a planned dose of 80 gray to a 5 millimeter depth. And then in this figure here, you can see a nice example case. So you can see this enhancing deep left frontal lesion that was resected using a minimally invasive approach, which I'll talk about a little more in a second. The CT scan there, you can see all the little beads with right after surgery that have been placed. We used, I think it was kind of some Surgicel as well as a glue sealant to try to keep those in place and not migrate. And then in C there, that's the initial post-op MRI showing a gross total resection. And in D, this patient had a really nice outcome where that was a 1-year post-op MRI with no local recurrence. So Dr. Keene is going to talk more about this, but briefly, What do I mean when I say minimally invasive? It's typically a small, like 6 to 8 centimeter linear incision that we're making. The craniotomy, so the bone opening, is about 3 centimeters in diameter most times. And then for a deep lesion, like the one that we were just looking at in that picture, we insert a tubular retractor pictured there under neuronavigation. And then there's been a variety, and I'm sure Dr. Keene will talk about this more, of potential benefits of these approaches versus traditional larger open approaches, but there's reduced parenchymal trauma, potentially few neurologic complications. Some series have shown faster recovery, less pain meds, or improved wound healing. So the idea for our study was just really to combine those two things. It was a single-center prospective trial at Ochsner from 2019 to 2021. It was sponsored by IsoRay, which was the company that makes the cesium beads. It included 21 adults with 1 to 6 newly diagnosed brain mets that required surgery. The decision of surgery was made independently of enrollment in this. They had to have a KPS of at least 60. Patients with prior radiation were excluded. Patients with life expectancy less than 3 months were excluded, but that's kind of a general criteria for us anyways when we're selecting patients as surgical candidates. It's not necessarily unique to this study. Primary outcome was freedom from local progression. Secondary outcomes were quality of life and other functional outcomes, the dosimetry, and complications, notably including radiation necrosis. And there were also Kaplan-Meier analyses for survival and distal recurrence. Looking at this in kind of a timeline format, so you have your patient with a new brain met diagnosis, and they underwent the craniotomy with placement of the cesium beads, again, goal of 80 gray to 5 millimeter depth. They had both a CT and an MRI within 48 hours to assess the resection and calculate the dosimetry. And then follow-up was a 2-week post-op follow-up, and then every 2 months for a year or for however long the patient survived. And at each follow-up, they were given a KPS score, ECOG score, a FACT-BR questionnaire, which is a quality of life, well-validated in oncologic setting questionnaire, mini mental status exam, and a contrasted MRI. So what did we find? First of all, there were very good rates of gross total resection. 20 out of 21 patients had gross total resection. The one patient that had a subtotal resection had a local recurrence. There were no other cases of local recurrence, and that panned out to be a 92% 1-year local freedom from progression. So that part was great. There were no cases of radiation necrosis. That was also great. However, there was only a 5.9-month median overall survival, which is low. That we believe was significantly confounded by the fact that this was occurring right during the COVID pandemic, and there were 5 deaths clearly attributed to COVID, which we believe unfortunately negatively impacted that number. But that is one of the main limitations of this work. Here are Kaplan-Meier figures. You can see the 92% 1-year local freedom from progression. The distal recurrence, 4 patients had distal recurrence at a median of 143 days post-op with a 54% 1-year distal freedom from progression. And that's looking at appearance of new lesions within the brain, not, I think it's greater than 5 millimeters away from the resection cavity. And then the overall survival curve, again, we believe severely COVID impacted. Median volume of the tumors resected was 10.6 centimeters cubed. There was a significant Spearman correlation between the V200 coverage and survival time, but then looking at it with a different univariate analysis, it did not retain significant prediction of overall survival, but maybe some signal there. In terms of our functional outcomes, There was no significant differences in KPS, ECOG, or mini mental status at various time points. Just looking at it numerically, KPS went from 80 pre-op to 90 post-op, but that was not a statistically significant difference. The FACT-BR questionnaire did show some statistically significant improvements in specific symptoms, including seizure frequency and improved memory and thought organization. But there were mixed results looking at different kind of emotional domains and no significant changes in the social domains. So in summary, this was recently published last December in the Journal of Neuro-Oncology, but we had 21 patients treated with minimally invasive crani plus brachytherapy seeds with high rates of local freedom from progression, no cases of radiation necrosis, but the two main limitations are poor COVID-impacted survival and the lack of a comparison arm. This was a single-arm study. So we thought, ideally you would have matched this to a standard of care cohort. So we went back and tried to do that best we could retrospectively. I'll talk about that for the remainder of this. We looked at our patients from 2019 to 2025 that had standard of care surgical resection plus radiosurgery. Of note, those cases were mostly what we would classify as open, so without the tubular retractors. And that time window is not exactly matched because basically in order to get the best matching for the histology and the age, we needed to expand the time window. But therefore the impact of the pandemic is different across those two groups, so we didn't have survival as a primary outcome in this retrospective matched analysis. But we did match for histology pretty exactly, for age within 10 years, and then we tried the best we could with tumor volume as well, but you'll see there's some variability there. And we were trying to look at and compare the local recurrence between the groups as well as the distal recurrence and rates of radiation necrosis. And then secondarily, we also did a cost analysis looking at quality adjusted life years in a couple ways, as well as doing an ICER analysis. So this is a list of the pairs of patients. The pathology there was matched exactly, except for one breast cancer patient having an ER mismatch. The ages are, like I said, tried to be within 10 years. The volumes, if you look individually, there are some pairs with some significant discrepancy, but if you look at the kind of overall numbers, medians and interquartile ranges, we felt like it was a reasonable comparison. Of note, there were two patients in the study, the original study, that just we could not find a good match for, so they were excluded from this retrospective comparison. But essentially what we found there is there were two cases of local recurrence in the radiosurgery group, none in this brachytherapy group. Again, going back to the original study, there was one case there, but basically there's no significant difference in local recurrence between the brachytherapy and standard of care. And there's maybe a trend towards improved distal recurrence in the so less distal recurrence in the brachytherapy group. Is not statistically significant, but you could potentially think that, maybe if these patients are getting treated up front, maybe they're able to resume systemic treatment earlier. That could be a potential explanation for why you might see that signal there. And then the cost effectiveness of this. So among 20 brachytherapy patients that we had data for, the median direct hospital cost is $14,000. And then the quality adjusted life year was 0.5, so it's $30,000 per quality adjusted life year. There was only data for matched pairs available. So we looked at that between the radiosurgery and brachytherapy groups. And the brachytherapy group had significantly lower median costs as well as hospital charges with comparable quality adjusted life years and net revenue. This is that's shown in a ICER diagram. So the bottom right quadrant of that figure are the dominant pairs where it's both cost effective and improved quality adjusted life years. There's two, conversely, in the top left dominated pairs where it's not good. The top right, one patient was deemed cost effective, and then there's four in the bottom left quadrant where it's kind of a trade-off where there was slightly lower quality of adjusted life years, but also lower cost. But overall, this did trend towards a value of negative $9,470 in the ICER analysis, favoring brachytherapy as a more cost-effective approach. I know in real life, with the way that this gets billed and I'm no expert on this, but the way that this gets billed with the radiation oncologist and their involvement, that it's not as simple as just these straight numbers. And those can be other considerations in terms of implementing brachytherapy as in your hospital system. And I'm continuing to learn more about that, but just based on those raw numbers, it did seem to be more cost effective. So that is really our work. In summary, the trial showed very good rates of local control, no cases of radiation necrosis, which is huge given the historical context of brachytherapy. And then our comparison analysis showed no difference in local control between standard of care and this, but it was, a small sample size, and potentially favorable rates in distal recurrence and significantly lower costs. The picture on there is the GammaTile formulation of this. So I believe the IsoRay company that sponsored this trial has since been absorbed by GammaTile. So this is what is out there on the market now for cesium-131 brachytherapy. It is FDA approved. And we're not involved with this, to be clear, but I think it's important context for this talk that they are very excited about their Rhodes trial. I went to SNO this year, and they presented it there as well as at CNS, their interim analysis of that. And they are showing improved recurrence-free survival with their GammaTile placement as opposed to standard post-op radiosurgery. And they're really running with that. We'll have to obviously see what the paper ends up showing with the full study. But for us, we were interested in potentially, that study though uses a lot of more open craniotomies, is my understanding. We were interested, and they were also interested in trying to combine their GammaTile formulation with the minimally invasive craniotomies that we do a lot of, and seeing if there's any kind of more functional quality of life or improved healing with that combination of things. But I don't know what the most kind of recent discussion on that is, but hopefully it's something we can work towards in the future. And that would also, give us the opportunity to repeat this study in a kind of different form in a context outside of the pandemic to make sure that our survival numbers actually hold up as well. I didn't put it on the slide, but I think another kind of important consideration for this would be, some centers are doing pre-op radiosurgery now, and that addresses, a lot of the potential benefits of brachytherapy are just the fact that you're doing it at the time of the surgery, and not allowing for that loss of follow-up or just delay in time that allows the other lesions to grow. So I don't know if it will happen, but a trial that's comparing brachytherapy to pre-op radiosurgery would also be very relevant and potentially a future direction for this work. But yeah, that's all I have. Thanks. Any questions?
I have a question. With the survival with your study, I know it was confounded by COVID, but you had such low rates of locally and distant recurrence with a survival average of about 5 months. So am I reasonable to conclude that the cause of death was something other than the brain metastases, like more systemic disease?
Yeah, I forget the exact number, but I think there were also a large percent of the patients that the death was, and sometimes, looking back, the study was done prospectively, but sometimes it's hard to tell, exactly why someone passed, just looking through their charts and such, but there were definitely a lot of patients that passed from just systemic disease progression, and that's, Dr. King might touch on it more, but I'm also doing a lot of just retrospective review of our minimally invasive series, just trying to look at the oncologic outcomes of our minimally invasive series overall, excluding these brachytherapy patients. And yeah, you find most of the readmissions, most of the deaths do seem to be just systemic disease progression, but then you also do find that some cases where just you don't know what happened, unfortunately. Yeah.
I think that's a really important point, that you're able to control the CNS disease well enough that that's not the patient's cause of death.
Yeah.
Any other questions? Thank you, Michelle.
Thanks.
All right, our next speaker is Dr. Joseph Keene. He is one of our tumor neurosurgeons at Ochsner, and he will be speaking about minimally invasive brain tumor surgery.
Thank you, Dr. Golden. Thank you to everybody. As she mentioned, I'm Joseph Keene. I'm one of the main brain tumor surgeons at Ochsner, along with my partner, Dr. Ware. So I'm just going to give a general talk about minimally invasive brain tumor surgery, just to give an idea of kind of what that entails, a little bit of how we've gotten here, and what that means for workflow and the patient. As Michelle was pointing out, minimally invasive sort of implies smaller, and certainly many of the surgeries we do are smaller when compared to an open craniotomy, which traditionally has been kind of a large opening, large scalp incision, large bone opening. But I think minimally invasive needs to be thought of as sort of a concept whereby the size of the surgery is kind of what it needs to be, with the idea that we're trying to minimize, get to the pathology, but minimize functional impact on the patient and expedite their return to normal function. Let's see. So the goal is zero footprint surgery. So can we do surgery without, causing any damage? And just like any field, everything's moving towards smaller and less invasive and quicker. Much of neurosurgery or brain tumor surgery, minimally invasive brain tumor surgery has been stolen from spine surgery. So, from the inception, spine surgery has been trying to do things smaller and less invasively. And so I throw these pictures up there somewhat for dramatic effect, but this is an open deformity spine surgery. So surgeons like this. This is, very large opening, lots of room to work. You can see anatomy very well. You can see your pathology well. But as you can see, the bottom right picture, very long incision, a lot of patient morbidity, a lot of postoperative pain, a lot of blood loss, can introduce a lot of medical problems just from the surgery alone. So naturally, spine surgeons have been, over many, many years have been working with technology to fine-tune the approaches and do things ever more direct and discreet. So throw another spine surgery photo up there, and this is kind of the mainstay of minimally invasive techniques. This is what is a lumbar laminectomy for removal of a herniated disc. And if you look at the top two center photographs, you see this tube sticking out of the patient's back. Well, that's kind of what Michelle introduced. It's a sort of the first iteration of a minimally invasive tubular retractor. So it allows the surgeon to directly go at the area of interest, the pathology, while providing a protective corridor so that the healthy tissues are protected, yet you're right down on the pathology. And and it's done through a small incision. You minimize tissue damage and patient morbidity. And then here's just another picture of that, a higher magnification. So this is, if you look at the top right photograph, this is looking down the tube through a microscope. And what you see there is the thecal sac that contains the nerve roots. The lamina bone has been removed. The herniated disc, which you can't see in this picture, has been removed. And so it allows you really to focus in on the pathology of interest. So the rationale of minimally invasive surgery, no surprise, less blood loss, less postoperative pain, reduced hospital length of stay, reduced ICU length of stay, reduced overall surgical morbidity, as Michelle presented nicely, less overall direct and indirect costs, yet you get the same surgical outcomes, and in the cases of brain tumor surgery, sometimes better outcomes. So jumping to brain surgery now, the inherent challenges of the old open craniotomy is that most metastases, most brain tumors are below the surface. So the only way to remove them is to provide an opening to that tumor. And traditionally, we've used, okay, the picture's up there. Traditionally, we've used these metal or rubber-coated retractors that hold the brain tissue open while the surgeon, accesses the tumor and removes it. However, these retractors inevitably distribute an uneven force on the brain tissue, and often it's at the surface where most of the eloquent fibers are, as well as the deep, important eloquent fibers can undergo damage. There's a very high chance of brain contusion, swelling, vascular injury, and then, as I mentioned, disruption of the eloquent fibers. And the deeper the tumor, the more difficult. There's much more extensive tissue dissection and a greater risk of disconnecting the important circuitry. So studies have showed longer OR time, longer ICU stay, more blood loss. And then if you have a larger opening, naturally you're at risk for more wound complications. So just like every field, you steal from your counterparts, and we sort of adapted the tubular retractor from spine surgery, made them, they tend to be plastic now instead of metal, but what's nice about this is it provides a fixed protective corridor that gets inserted into the brain, and the surgeon can introduce and remove instruments without inadvertently bumping into the tissue and damaging it. It also, they can be inserted using advanced MRI techniques in and around and to avoid eloquent circuitry. And they come in all sizes and shapes depending on where the pathology is. So they're uniquely suited for deep brain tumors. So this is This is our spine tubular retractor, and this is, I have a video that will show you, but this is the tube being inserted into the brain surface. So this slide kind of maybe belabors the point, but open surgery can be complicated by injury that you don't realize during surgery. The retractor blades can damage the tissue, but we're also using a microscope that has very high illumination, and that the heat temperature of the light can damage the surface of the brain. And then we talked about how if something's deep, you can inadvertently disconnect important circuitry. So the tube allows us a nice protective corridor, but then we need a way to get that tube to the brain tumor, and the mainstay for that is diffusion tensor imaging, which is an advanced MRI technique if you're not familiar with it or don't use it in your regular practice. And basically, it's it measures the movement of water molecules along axons and produces these color-coded maps of important circuitry. So in particular, the main ones we usually always think about are the movement and sensory fibers, the speech fibers, and then some other more nuanced fibers. And so we can preoperatively use these color-coded maps, choose a trajectory in and around these tracks, and have a nice trajectory down to the tumor already planned. So just the basics. For the color-coded maps, blue represents superior to inferior fibers, green anterior to posterior, and then red the fibers connecting the two halves of the brain. In this picture, I won't go through all these, but the red ones top to bottom, that's the corticospinal tract, which involves mainly motor function. The green is the arcuate fasciculus, which connects the receptive speech areas to the expressive speech areas. So very important, often involved in many of the tumors we're removing. Tumors seem to like to grow around these tracts. So what it culminates in is what we call a transsulcal parafascicular approach, and sulcal just refers to the trough in between two folds of the brain. We've determined that that's a safe area to enter if feasible. And so you make before surgery, like I mentioned, you pick your trajectory in and around these fiber tracts. You make preferably a small opening. And then at the brain surface, you make a very small incision, and then you insert the tube using our navigation, which is basically when we match the patient's head to the MRI, and it converts it into a GPS type of technology. And so we use that in combination with the color maps, and then we insert the tube down to the tumor. And this allows us to access tumors that are deep-seated that in the past wouldn't even probably have been attempted, and we hopefully minimize damage to those white matter fiber tracts. So this is a video. We have videos, but this is a nicer video than I have, and hopefully it plays, of J.D. Day, who was a neurosurgeon up at Arkansas.
Six-pillar minimally invasive approach for a metastatic brain tumor. The patient's a 62-year-old woman with a fairly recent diagnosis of melanoma.
Well, if you ignore the volume, this is a tumor within the basal ganglia. These are the fiber tracts. The red is the corticospinal tracts for movement. And what he's pointing out is that they are pushed medially and posteriorly. Here's the color map.
You can see the left-sided corticospinal tract.
Actually, maybe you can hear it. I'll just keep quiet.
Preoperative planning included approach trajectory planning for use of the brain path retractor tube. The craniotomy was performed at the site of the pre-planned entry site.
So he's going to make a cut
Technique
in the arachnoid and insert the
high
tube
definition
in that trough between the two
with a
folds.
Storz VTOM exoscope. The pre-planned sulcal entry point is opened. The arachnoid is opened widely at the sulcus to allow introduction of the brain path tube. Here, the sulcus is prepared sufficiently.
So you have to be
for
careful of
introduction
blood vessels,
to
mainly arteries in that area.
brain path is guided using image guidance along the pre-planned approach trajectory. It's
So
slowly
this
advanced
is a little bit
down to
obscene.
target depth.
It looks like you're going to damage the tissue, but actually the tube pushes the brain tissue away, and the resistance of the brain actually works to help get that tube down
Light,
there.
Continuous pressure down to the tumor. The obturator is removed, and the exoscope appropriately positioned to see into the depth. Using the Myriad resection instrument, you can see how the tumor is resected and suctioned. Otherwise, regular microsurgical instrumentation can mostly be used down the tube. The tumor is resected from the surrounding normal appearing white matter. Once the resection is completed, hemostasis is obtained. Here you can see that the normal thin bipolar.
So if there's any bleeding at the end of the case, you can visualize it very well, cauterize it with the
hemostasis is
the cauterization, and then you can,
small amount of
in this case, he's
flow
inserting a hemostatic
is
agent that
placed.
helps with stopping any bleeding. And then, as you
Excess
can tell, it
blood
looks
seal is
like we
irrigated
almost weren't even there.
away, and the tube gently.
So that's kind of how it happens. As Michelle mentioned, we've got a lot of series. We've been doing this for, well, I've been an auctioneer for about 10 years, and I first learned these techniques in training and fellowship. And so we've been doing it at least 10 years, and we've got quite good series now, and we're just starting to look back on our results and publish, trying to publish these and get that out there. So I'd say 80% of our brain tumor surgeries now are minimally invasive when they can be. If the tumor is more toward the surface, sometimes I don't bother. It's not helpful. But anyway, here's a case that exemplifies the minimally invasive approach, but sort of our multidisciplinary team, and then also how great immunotherapies have been at controlling disease. So this is an 82-year-old male who was diagnosed with stage 4 metastatic melanoma. He presented to us with progressively worsening vision changes, just not acting right, not feeling right. And then he was found to have multiple brain mets. I believe the number was about 7. And he was initially diagnosed in 2020 with metastases. 2024, they started him on Opdivo and Yervoy. Had some difficulty tolerating that due to some pretty significant arthritis and a rash. He was then sent for 2 fractions, or underwent 2 fractions of whole brain radiation at an outside hospital, but still was having progressive vision problems and just not acting himself. And so everyone thought, well, that's probably just all the treatments. He came to us and saw that he had these large brain lesions, he had 7 brain lesions. 3 of them were quite large. We ultimately decided to take him for surgery, and because of the minimally invasive capabilities, we were able to do 3 surgeries in one sitting. So we removed all 3 of the large ones, left the smaller ones, with the idea that he would restart immunotherapy and then undergo Gamma Knife. But since then, he's restarted immunotherapy, his vision's improved, he's like a different person, and actually radiotherapy is on hold right now, so he's got good systemic control. So this is just the scans. You can see 2 large lesions in the occipital parietal region, and then 1 more toward the front. So we generated our color maps on the left. So these are the language maps. On the left, the tan dots or parcellations. In the back are the receptive language areas, and the orange ones in the front are the expressive language areas, which are connected by the green fibers seen on the right screen. So if you just, I mean, it's very simple. You can tell that we have a nice corridor toward those tumors. And then when we looked at the optic radiations, which is why his vision was being compromised, you can see that the majority of those fibers are inside the tumor, so we felt comfortable we weren't gonna go right through those. And then this is his corticospinal tract or sensory motor fibers, and those are all pretty central, not at risk with the lesions in the back, somewhat at risk for the lesion in the front, but safe enough away. So this is the post-op scan. We were able to get all those out, gross total resection, and it was just too many cuts to show his other lesions, but for the most part, they're all gone right now. He's responded very well to immunotherapy. So I'd say this is, just like Gamma Knife, we're pushing the envelope on how many we'll treat. I think this minimally invasive technique allows us to, take people for surgery as well. So that's it. Thank you very much. Any questions?
I'll ask a question. You mentioned that sometimes with superficial tumors, you'll do an open craniotomy just because there's no need for the minimally invasive. Are there any other situations where you feel like open craniotomy would be more beneficial than surgery?
Yeah, if the tumors are superficial, then the tube, it's sort of in the way, if you will, and it's right there. So we'll still tailor, because of using these techniques, I don't feel that need, like in that spine case where I need to see everything. I've become very comfortable with small anatomy now, so it's like I'll be able to really tailor that craniotomy just to the size I need. Tumors that are, outside the brain, which tend to be more benign entities, are going to respond better to open surgeries. Or if a metastasis is sort of in the brain, but also dural based, sometimes it's just easy. It's going to be more natural. It's always better to go outside the brain than inside the brain. So in that case, I'll just use a natural corridor.
I think I would say too, this is kind of how we define it, but like, if you look broadly, minimally invasive, like you're saying, it's more of a concept. Like, when we're saying the superficial ones are open, it's still often this, with brachydactyly, where especially, it's still often very small, like say craniotomy, a small skin incision. It's just the tumor's right at the surface, so you're not putting in the tubular retractor. And then some of the extra axial stuff, we don't necessarily, but Dr. doesn't, like, people will do little eyebrow, small craniotomies, the eyebrow incision, like people will talk about that as being minimally invasive, but it's kind of a different definition of minimally invasive for some of the extra axial stuff, but it's like minimally invasive, even though we kind of define it for what we're doing as using the tubular retractor, it doesn't necessarily have to be using the tubular retractor. It's kind of a broader concept.
Yeah, I had a couple slides in here. I took it out just because I thought it would be confusing, but what Michelle's referring to is you can make smaller openings in the bone, not use the retractor, but for instance, she was referring to, we can make an eyebrow incision for stuff that's more frontal. You never want to really cut on the forehead, obviously, because that doesn't heal great. But now we've got approaches where we make a nice incision in the eyebrow, and then we just remove a really small piece above the orbit, and we can either enter the brain itself, or we can get at something that might be outside the brain. And that's a concept, minimally invasive, but also called keyhole. And it's the idea of if you look through a keyhole through a door, you can kind of still see the whole room. You know, if you just look straight, you can't really see much, but then if you change your angles, and so it's this concept of keyhole approach. All right, but thank you.
All right, next up, we have Dr. Darshan Trivedi. He's our neuropathologist at Ochsner, and he is going to be talking about DNA methylation profiling and classification of new CNS tumor entities.
Good morning, everybody. Thank you, Dr. Golden, for inviting me to speak today. My name is Darshan Trivedi. What is it that a pathologist does? We are the diagnostic physicians of the hospital. So this is talk about one of the tools that has recently emerged, helping us in those diagnostic protocols. No financial disclosures. So what is DNA methylation profiling? It was first introduced in 2018 by an absolutely phenomenal work group at the University of Heidelberg, Germany. They published a paper in Nature showing that they had developed a classifier system using DNA methylation analysis to aid in the diagnosis of CNS tumors. The initial classifier contained about 82 tumor classes with about non-neoplastic control tissue types. And the most recent version published last year is version 12.8, and that has greatly expanded to about 184 classes. Our most recent publication of our guidelines published by the WHO was published in 2021, and even just 3 years after the publication of the Heidelberg paper, the WHO has characterized this platform as essential or desirable for the diagnosis of multiple tumor types. General principles. So based on the observation that patterns of DNA methylation across the genome are correlated with the tumor type in a reproducible manner, epigenetic changes occurring because of specific genomic alterations can also influence the DNA methylation profile of a neoplasm. And comparison of the findings to a reference set, which is the classifier I was just talking about, of the defined methylation classes, the closest match can be determined along with a confidence score. How this is done? Well, a lot of this is proprietary, so I can't really speak about it. But really what they're using is a methylation bead chip produced by the private sector. That bead chip contains about 450,000 interrogated CpG sites attached to both a methylated bead and an unmethylated bead. If the tumor site is methylated, transcription will proceed forward at that site. If the tumor site is unmethylated, transcription will proceed forward at that site with the unmethylated bead. So, simple as that. That is all of that data is then fed into a machine learning algorithm using that classifier data set, using iterative regression analysis. That data is then matched to the data within the classifier set, and a confidence score based on that information is developed. So what does that output kind of look like? So this is a classic kind of tumor example that we often use to stump pathology trainees and people taking their boards. So at low power, we're seeing a very, very hypercellular, busy neoplasm. That's the top image right there. On the bottom image is a much more high-power, zoomed-in image. And we can see a lot of very ugly cells that really shouldn't be there in the brain. Now, a quick look says, okay, ugly cells, this must be something aggressive, malignant, high grade. But To the trained eye, what we are not seeing is actually necrosis, microvascular proliferation, mitotic activity, the things that would be characteristic of a malignant neoplasm. So somebody was stumped by this. They sent it to a facility that does DNA methylation profiling, said, help us out with this. Let's see if we can get some more data to try to figure out what the proper diagnosis would be to inform people like Dr. Golden about what the proper treatment protocol should be. So the facility they sent this to, one was the National Cancer Institute at Bethesda. The other is DKFZ, which is the facility at Heidelberg, Germany. They're using both of their classifier data sets. And the answer that came out is a pleomorphic xanthoastrocytoma. Now, even though this is a very ugly-looking tumor, a pleomorphic xanthoastrocytoma is actually a very low-grade tumor, and surgical resection is often curative without the need for additional chemotherapy and radiation. So that's what this whole platform is there to inform people about, is do we need to be aggressive in the therapies of these patients? Do we need to be not so aggressive in the therapies of these patients? You can see the confidence score on the rightmost side, and that is 0.99, which is as high as it goes. So very, very high confidence about this diagnosis. On the bottom plots, you can see a copy number variant plot showing the entire genome graphed across this plot. And you can, in particular, and maybe you could see, is there a cursor or pointer? Chromosome number 7, right there, all right? The characteristic mutation of pleomorphic xanthoastrocytoma is the BRAF gene. So that's located at chromosome number 7, so that's what that's picking up right there. Also, a number of other variants are there as well. So then you take all of that multivariate data, you use a UMAP, which is a Universal Manifold Association plot, I believe is the correct explanation for that abbreviation. And that, using the machine learning algorithm, will plot it smack dab right in the group that are the pleomorphic xanthoastrocytomas, according to those classifier data sets. So very, very high confidence that this is the diagnosis that needs to be made. Here's another example from kind of the opposite end of the spectrum. Here again, we're seeing very, very hypercellular tumor at the top image. At the lower image, we are seeing these tumor cells kind of gathering around these blood vessels that are very, very tiny in caliber, but seem to have a lot of kind of acellular material aggregated around them. And then if you look back at the higher power image, you can notice that there's a lot of discohesion between the tumor islands that are aggregating around those blood vessels. So very, very interesting looking tumor, not really definitive appearance for anything, really. So they do their analysis, and again, same exact spot, we're seeing a lot of alterations in busyness at chromosome number 7, but we're also seeing a lot of point mutations and deletions all throughout the genome, as well as some elevated copy number changes. Interestingly enough, when plotted, this comes out with the answer CNS tumor with BCOR and BCOR-L1 fusion alterations. Now, this is the interesting part about this platform. BCOR and BCOR-L1 are X chromosome-based genes. Look at the X chromosome all the way at the end of that CNV plot. Are you seeing any alterations there? No. So this platform is not picking up the characteristic alteration that would be associated with this diagnosis. What it is picking up is all the other associated methylation alterations that would commonly be seen in this tumor. So when they grafted onto you did their machine learning analysis and then grafted on to the UMAP plot, the answer they got is that this is consistent with a CNS tumor with BCOR-BCOR-L1 fusion, even though the genetic analysis is not actually showing that characteristic molecular alteration. Yes. It's not, so that would be what you would use NGS for. Right, you would use NGS to pick up those alterations. This would be in addition to that NGS analysis.
If you want to get the BCOR-BCOR-L1 fusions, I think it's better to get the RNA sequencing rather than just methylation.
Exactly, and any institute that does the DNA methylation profiling will also do RNA sequencing in addition to that to provide additional data. So, very good question, thank you. So, if you look at the confidence score then, according to the Bethesda database, this is a 0.81 score, and the Heidelberg database is actually showing a high confidence score with this, just based on that methylation profile. So let's just go through a couple examples of what this will output. So I perform my histologic analysis. I'm seeing a low-grade tumor, very characteristic for an oligodendroglioma, which is a low-grade infiltrating glial neoplasm. I'm not seeing any high-grade features. I do the NGS analysis. TERT promoter mutation is something that is very scary and something that jumps out at us as a characteristic for a high-grade mutation. But when seen in combination with an IDH1 mutation, that is very characteristic for an oligodendroglioma. So again, a very low-grade tumor. We do the chromosomal analysis. We see the characteristic chromosomal alteration for an oligodendroglioma, 1p19q full arm co-deletion. So all of that data gives us that diagnosis. Now we are testing the DNA methylation profile and the classifier databases against what we know to be true. So this is much more of a kind of a positive control kind of situation, okay? The family is kind of the broad spectrum classification. So this lands in the family of diffuse glioma, IDH mutant. The confidence score is 0.99. And the class designation is oligodendroglioma with all the rest of it in there. Also 0.98, pretty high. So again, this is a positive correlation, and we have a grade 2 glioma. So the NIH actually, the WHO actually suggests us to list all of this out in our diagnostic reports. I try to take it easy on my oncologists and neurosurgeons and make it a little bit simpler than that. Here's another example of the opposite thing. So in this case, we are histologically seeing a high-grade infiltrated glioma. The most common high-grade infiltrated glioma, glioblastoma, most common tumor we encounter. Okay. I do the NGS analysis, TERT promoter mutation by itself, characteristic for glioblastoma. Chromosomal analysis shows gain of chromosome 7, loss of chromosome 10, also very characteristic of a glioblastoma. But when you put it into this DNA methylation profiling database, no matches are found at their level of significance. What is their level of significance? They want it to be at 0.9. Why they chose that number, I do not know. But that's the level that they have established for their confidence interval. So in this case, no high confidence match is found in the family and no high confidence match is found in the class. So based on histology, based on molecular profiling, we have a glioblastoma. Based on DNA methylation profiling, we do not have a match, but we should proceed forward with the data we have. Okay. This is a very characteristic stumbling block. In many pediatric tumors, we do not have a good name for a lot of what happens. A lot of them are very heterogeneous. They have mutations, but they do not have classic histologic appearances. They have classic histologic appearances, but they do not have classic mutations. In many cases, they have neither of those things. So in this situation, we have a low-grade glial or glial neuronal tumor. It shows an FGFR1 mutation, but it shows no chromosomal alterations. The DNA methylation profiling really can only establish that, yes, this is a low-grade glioneuronal tumor, but it cannot further specify based on the methylation spectrum of this tumor. And finally, what happens when we encounter something that is truly bizarre and unique? So in this stage, we have a glioneuronal tumor, likely from an adult case. It shows a very, very peculiar NTRK2 mutation, but, fusion rather, but we don't really have that characterized within our WHO classification. There are no chromosomal alterations. We have a diffuse glioneuronal tumor, non-defined type, as our confidence score, and the Heidelberg database puts out a glioneuronal tumor, kinase fused, with a strong confidence score, but there is no real name for it, and when you look through the classification of the WHO, there is nothing that matches this. So this isn't truly a new tumor type discovered by this DNA methylation profiling. So what are overall the limitations for this? Well, there's an issue with content of tumor within the sample produced. This is a very tissue-intensive process, especially since you would probably need to do NGS and, as you stated, RNA sequencing and multiple other platforms as well. If you submit a sample, say from the periphery of what is classically a glioblastoma, you can get very, very weird outputs because they haven't had the full epigenetic expression of the truly high-grade areas of that tumor within the more lower-grade areas of that tumor. So what is, in all other sense, a glioblastoma could be outputted as a ganglioglioma, which makes no sense and you can't do anything with. A substantial number of cases result in low confidence matches. So as you saw, if it falls below that 0.9 confidence score, what do you actually do with that information? Is it truly a match for that case, or is it something more suggestive of a tumor leading towards that case? Low-grade glioneuronal tumors can be ambiguous, as we saw in that example. There are not a lot of well-defined tumors. Things that are well-defined histologically, such as pilocytic astrocytoma, ganglioglioma, all of these low-grade tumors tend to bunch together a lot within this machine learning algorithm. And one interesting thing, which is a little anecdotal story I have for you, is that a patient, which is the pictures on the right, was about an 80-year-old lady with a sinonasal tumor originating from the skull base, very high grade in appearance, very ugly looking. Because the surgeon who did this operation was a neurosurgeon, the tissue went to a neuropathologist. The neuropathologist could not figure out what it was, so he sent it for DNA methylation profiling. And what that DNA methylation profiling picked up was a SMARB1 or a SMARCA4 deficient tumor. Now, in the neuropathology context, if you say that, if you're studying for your boards, you say that mutation, there is only one diagnosis that comes up: atypical teratoid rhabdoid tumor. What's wrong with that answer? An atypical teratoid rhabdoid tumor does not occur in the skull base and extend into the sinuses. It occurs in the posterior fossa, a completely different location. It does not occur in 80-year-old women. It occurs in children, usually under the age of 10. So how can it possibly be an atypical teratoid rhabdoid tumor if none of the other demographic or histologic or other suggestive data points towards that? That mutation is so heavily weighted within the machine learning algorithm that that is the only answer it can give you. And keep in mind that this DNA methylation profiling is really to date only being used in neuro-oncology. What that answer was is an INI1 deficient sinonasal tumor. It just happens to have the same mutation as an ATRT. If you do head and neck pathology as I do, that would be the obvious answer. So what are the recommendations? DNA methylation profiling should be considered when a differential diagnosis needs to be resolved to inform clinical care. The WHO lists several tumor types where DNA methylation profiling is considered desirable or essential, and results should always be interpreted in the context of all additional histologic, immunohistochemical, and sequencing information. Where do you send this? There are two institutions available right now to us. The first is the National Cancer Institute, associated with the NIH in Bethesda. This is a free service. It's paid for by your taxpayer dollars. It has the largest available clinical database. They have a tremendously high volume, so it will take about a month or two. So if time is of the essence, this is not what you should send it for. The problems is that, A, they cannot really provide you a grading. You have to do that with histologic and immunohistochemical analysis. It is very tissue intensive, and because this is a government agency, it is very much beholden to what is going on in the government at the moment. I did send a case last November for DNA methylation profiling, and the very next day is the day the government shut down. So I had to wait 3 months for the answer to come back. St. Jude's Children's Research Hospital is an excellent facility. They also provide free services, They will turn it around within about a month, and they have a tremendous amount of experience using very, very limited amount of tissue. So excellent facility. The only limitation is the patient has to be under 19 years of age. That's it. You cannot send an adult patient to St. Jude's. So what do you do with all this information? There's the classic diagnostic peril between lumpers and splitters. Splitters want to drill down to the minutia of every molecular feature and create a new tumor entity for every single one of those features. Lumpers want to aggregate all of that data together to provide the most clear answer for our clinical colleagues such that they can move forward with the patient's treatment. Literature, unfortunately, has a clear splitter bias. It's very easy to publish that, oh, I'm finding this unique little change right here, unique little change right here. This should be a new tumor, and you should name it after me. Subclassification should be based on prognostic and predictive significance. Okay? Our CE Impact now, which is our kind of guiding whiz and elder community within neuropathology, has decided that they needed to step in and actually rein in some of this behavior. So what they've established is that you should have clear prognosis and expected responses before you can declare a new tumor entity. They should have unique clustering patterns in the profiling. The associated molecular profile should be comprised of either a distinct single or combination of genetic drivers, and the associated microscopic features should be very typical or at least reproducible in these situations. So in conclusion, this is a new technology. A lot of data is being generated by it, and it offers the opportunity to further refine and classify all of this information that we are gathering now. But we have to understand the capabilities and limitations of that platform in order to properly assess the information it outputs. And complexity should never outpace clinical utility. Everything I said in this talk is based on these two papers. Ken Aldape is largely the American scientist and neuropathologist driving a lot of these innovations. He's since moved from the NIH to the Mayo Clinic. And the CE Impact Now 10 is the recommendations for new tumor classifications. And that is it. Thank you very much.
How can you confirm that SmartV1 methylation defect is causing tumor? As you mentioned, that tumor presentation is unusual, considering all kinds of clinical features and application-wise. And then only methylation defect you asked, but have you seen the sequencing or mRNA level or protein level to confirm that this is actually causing harm?
Yes, you would have to verify all of this with sequencing. So the first step to do would be sequence the tumor. If you see characteristic molecular profile within that sequencing, then you don't really need DNA methylation profiling. If that is somewhat heterogeneous, not contributory, or otherwise generating kind of an ambiguous answer, which it does many times, then you can proceed forward with DNA methylation profiling in hope that that methylation profile might provide a better answer.
But not all the time. The sequencing defect is causing methylation issue. For example, like RD1A in uterine carcinoma, even though they have a mutation, they are not actually causing methylation problem. And then DNA3A as well, even though they have mutations, not always they are causing a methylation defect or mRNA defect. But if the sequencing, even though sequencing is normal, I think we should go to the next step, like mRNA or like protein level, to see actually the protein is not working.
No, that's very good insight.
Why is it? I mean, in the clinical field, if it is just showing the methylation defect, and then the clinical phenotype is not matched exactly with the SmartV1, it's hard to say that this is it until we prove the protein or like other requirements.
All right, thank you very much.
Our last presentation today is by Dr. Kareem Fakri. He is a radiation oncologist at LCMC, and he'll be talking about considerations for CNS management in small cell lung cancer. Thanks.
Hey, thanks so much for having me today. Appreciate the invitation to speak. I'm a radiation oncologist within the LCMC health system here in New Orleans. So I work at University Medical Center and West Jefferson Medical Center. So as we know, brain metastases are extremely common in small cell lung cancer, almost twice as common as in non-small cell lung cancer. And about 10 to 20% of patients will present with brain metastases at diagnosis, many of whom have asymptomatic disease. And the incidence of developing brain metastases increases over time, as you can see in this figure from the Slotman study, that these patients approached about a 50% rate of brain metastases at 18 months. The reason for this is the blood-brain barrier, which creates the brain as a sanctuary site. This was recognized in the 60s and early 70s as we saw that chemotherapeutic agents would provide really significant responses extracranially, but then patients would have high rates of failure in the CNS. And this led to the development of the technique of prophylactic cranial irradiation, or PCI. So these first generation trials that were done in the 70s and 80s showed that PCI was very effective in preventing the development of brain metastases. But each of these studies by itself lacks power to demonstrate a survival benefit, possibly due to the older techniques that were used in terms of radiation and higher doses of radiation that were used, which were more toxic. And there was also concern being raised about the potential neurotoxicity of this treatment as well. This culminated, though, in the publication of the OPERA meta-analysis in 1999, which looked at 7 randomized controlled trials with over about 1,000 patients, all of whom had a complete response after induction therapy. And we saw that at 3 years, there was about a 5 to 6% absolute benefit in overall survival, which was attributed to about a 25% reduction in the development of brain mets at 3 years. Unfortunately, there were a lot of limitations to the studies included in the meta-analysis. Most of them regarded imaging staging, so patients did not receive PET CTs at this time for staging. And there may have been a lot more patients with extensive disease than were detected. When patients completed their induction therapy, their restaging and treatment response was done with just a chest X-ray on most studies, and so complete response rates were probably overestimated. But the most important limitation was the lack of MRI. And we know that up to 15% of patients with small cell will have asymptomatic brain mets at diagnosis. So in reality, some of these patients on these studies were probably not receiving prophylactic cranial radiation, but therapeutic cranial radiation for unknown brain metastases, thereby inflating the survival benefit of PCI. A meta-analysis was done more recently. This study was published in 2023 in JCO, and they looked at over 200 studies with over 50,000 patients. And if you look at all those studies together, there was an associated survival benefit with PCI. But when you pared it down to studies that used MRI before to stage patients prior to PCI, there was no longer a survival benefit. And then furthermore, when they limited it to patients with to studies with randomized trial design alone, there was also no longer a survival benefit, suggesting the importance of patient selection. The best study that's been published in this space is referred to as the Japanese trial, or the Takahashi trial. And this was the first randomized controlled trial of PCI versus no PCI that required MRI staging. It included about 160 patients with extensive stage disease who had negative brain MRI. And the trial was actually stopped early for futility because the patients who received no PCI in the experimental arm actually were approaching better survival than those who did receive PCI. And that was about 10 months in the group that received PCI versus 15 months in the group that did not. In the non-PCI arm, there was an MRI surveillance protocol that included MRIs of the brain every 3 months for the first year and then every 6 months after that. And unfortunately, about 80% of these patients on the study did develop brain metastases. But those who didn't have any worsening of their overall survival, which suggested that they were salvageable with radiation. And on the other side, there are 20% of patients who were able to be spared from radiation. Unfortunately, we don't really have the same kind of randomized data in the limited stage setting yet, but we do have retrospective data that is suggestive of a similar outcome. So on this study, there were about 300 patients who were propensity score matched, and about 2/3 of them received PCI and about 1/3 did not. And all of them underwent MRI staging. And again, we saw no difference in overall survival. The reason that we care so much about whether or not to give PCI is about the potential for neurocognitive toxicity. You can see on this pooled analysis of 2 RTOG studies that about 600 patients were included on. About 2/3 of them received PCI and 1/3 did not. And you can see in various cognitive domains, as well as in patient-reported cognitive function, there was worse outcomes in terms of neurocognitive toxicity in the patients who received PCI at 6 months, and that persisted at 12 months. There's a number of different things that contribute to the risk of neurocognitive toxicity after PCI. Age is one of the most significant ones, with the cutoff of 60 being significant. Doses of radiation is also significantly associated with neurocognitive failure, but this has been sort of clarified on other randomized studies, and a low dose is used as the standard approach now. Patients with the worst baseline cognitive function are more likely to develop cognitive failure after PCI. And then you also have to weigh the alternative of developing brain metastases, which typically can have a worse cognitive impact than the radiation itself. This graph also shows a number of adverse events related to different cognitive domains, with the top bars showing patients who received PCI, and on the bottom, patients who did not receive PCI, with significant increase in cognitive-related adverse events going out to 3 years, which is worse with the patients who received PCI. And this has really affected patterns of care. Despite PCI being a Category 1 recommendation for limited stage patients in NCCN, about 40% of patients do not receive it, mainly due to toxicity concerns. And there was also a 2019 survey of about 500 radiation oncologists that showed that after that Japanese study was published, PCI dropped significantly and very quickly in patients who have extensive stage small cell lung cancer. There are ways that we've been studying toxicity mitigation for patients receiving whole brain radiation and PCI. The 2 main developments have been memantine use and hippocampal avoidance. Memantine you've probably heard about as a drug in the Alzheimer's space, and it's been shown in various randomized studies now when added to patients' whole brain radiation to reduce the risk of neurocognitive failure. Which is a small but significant improvement. And then added on top of that is hippocampal avoidant whole brain radiation. And you can see in this figure on the top 2 images are showing a hippocampal avoidant whole brain radiation plan. And these bottom 2 images are showing a standard conventional whole brain radiation plan, where the whole brain is sort of treated through and through. Whereas on the top, we're using a fancier technique of radiation called intensity modulated radiation, or IMRT, which can carve out an area in the shape of the hippocampi to avoid dose to that area. And that's also been shown with memantine to reduce neurocognitive failure. That being said, rates of neurocognitive failure are still relatively high. And so this has led to sort of developing the case for MRI brain surveillance rather than upfront PCI. The rationale is, again, based on those older studies that were done that showed a survival benefit. Those were done in the pre-MRI era. Now that we have MRIs, we can detect brain metastases early and salvage them early if needed. Ideally, this approach will avoid neurotoxicity in at least a subset of patients, and it's been shown in some studies to be cost-effective. So salvage radiation has been studied retrospectively in a number of studies. And the first study by Yao and colleagues, this was a real-world multi-center study of about 120 patients with limited stage disease. About half of them received PCI and half received MRI surveillance. And those who developed brain metastases in the MRI surveillance arm were salvaged with whole brain radiation, and there was no difference in overall survival. In the second study by Lee and colleagues, this was a multi-center study of about 1,300 patients with limited stage disease. Similarly, about half received PCI and about half didn't. And while PCI reduced the rate of brain mets, it did not have a survival benefit. And that makes sense intuitively. PCI is able to treat subclinical micrometastatic disease and prevent the development of brain mets in the future. But we have to ask, what's the clinical utility of that if we're still able to salvage patients who develop brain mets down the road? It was also shown on this study that patients who received SRS as their salvage radiation had a better survival than those who received whole brain radiation. So SRS stands for stereotactic radiosurgery. This is a form of targeted focused radiation which can be delivered with millimeter accuracy and allows the delivery of high dose of radiation to small areas with low dose to surrounding normal brain tissue. The goal of SRS is to escalate the dose of radiation to the target and thereby improving local control, and to reduce the dose of radiation to normal brain tissue, thereby reducing the risk of cognitive decline. In this figure of a patient with 7 brain metastases treated with linear accelerator-based SRS, the red is the prescription dose, and the blue is 50% of that dose, which you can see is very well confined to the area being treated. And in this patient's plan, the mean dose of radiation to the whole brain was only 1.7 gray, gray being a unit of radiation, whereas a typical whole brain plan is treated to 30 gray, and the mean brain dose is about 30 gray in those cases. This is showing what we call the beam's eye view in a linear accelerator-based SRS plan. So you can imagine yourself sort of sitting from the head of the machine where the beam of radiation is coming out. And what you're seeing moving are these little tiny lead leaflets called MLCs, or multi-leaf collimators, and they're creating really tiny apertures through which the beam is allowed to pass. And as that's happening, the arc is rotating around the patient from various angles. And by creating all of these various angles and apertures, we're able to create buildup of radiation in very small focused areas and low dose spread of radiation to the normal brain tissue around. The way that I describe it to patients is thinking about it like a spotlight on a stage. If you have 3 or 5 different spotlights converging on one place on the stage, it creates a very bright spot where the speaker is standing, but a lighter, less bright area and where there's just one beam or one spotlight coming from. And if you can imagine doing that to nearly an infinite number of times, that's how SRS kind of converges the dose of radiation. This is kind of the best data that we have for SRS salvage for patients who develop brain mets with small cell lung cancer. This is the FIRE SCLC study, which stands for first-line radiosurgery, as compared to standard whole brain radiation. And they included about 1,000 patients from various institutions. About 13% of these patients had a high burden of brain mets, with more than 10 brain metastases at the time of development. And you can see in the graphs on the right, so this is showing the entire cohort receiving SRS versus whole brain radiation, that survival was significantly better in those who received SRS. And then they did a propensity score matched analysis, and the survival benefit of SRS remained over whole brain radiation, with SRS leading to a survival of 6 months versus whole brain with 5 months. On the right side, you can see a figure similar to one that I showed earlier in the talk, where there's an incidence of brain metastases over time. And you can see that patients who received SRS are more likely to develop additional brain metastases in the future. And again, that makes sense. You're not treating the whole brain, you're not treating micrometastatic disease, so it's more likely that they develop future lesions in the brain in the future. But as long as, the implication is that as long as you're doing regular MRI surveillance, you can catch those early and treat them with salvage. Other concerns with SRS are development of neurologic mortality and leptomeningeal progression, but they saw that the rates of those were quite low on this study. So we have a randomized study open now to try to answer this question more definitively, where patients who develop brain mets with small cell lung cancer are randomly assigned to receive salvage radiation with either SRS or hippocampal whole brain radiation. So that'll help guide things in the future. Another area that's sort of uncertain right now is how PCI factors into immunotherapy. All the studies that have been done to date were not in the immunotherapy era, so it's hard to know how PCI interacts. The best data we have in this space so far is from the Adriatic trial, in which patients with limited stage disease received adjuvant immunotherapy after upfront systemic and radiation therapy. And it showed that there was actually an overall survival benefit associated with PCI, and it was actually pretty significant, from 50% to 62% at 3 years. But it's hard to hang our hat on this data since PCI was done at physician discretion, and we're not really sure how MRIs were used on this study. So that kind of segues to the last topic, which is the MAVERICK trial. This is an open SWOG study, which is hopefully going to provide definitive evidence on the role of PCI in small cell lung cancer going forward. These patients all receive PET staging, they all receive MRI at baseline, as well as an MRI surveillance protocol similar to the one used in the Japanese trial, where they receive MRIs every 3 months for the first year and every 6 months for the second year. It's an inclusive study of both limited stage and extensive stage patients, so it should be able to guide data for both of those and treatment recommendations for both of those populations. And they're looking at overall survival as their primary outcome. So this should answer the question, is PCI, is MRI surveillance non-inferior to PCI in these patients? And they're also looking at cognitive and quality of life outcomes. Until we have this data, I think it really comes down to patient selection in terms of whether or not to offer PCI. Thinking about those baseline factors that may increase their risk of developing neurocognitive toxicity, such as performance status, age, and baseline cognition. In terms of stage, we already have data that's randomized from the Japanese trial that extensive stage patients don't have a survival benefit to PCI if using MRI surveillance. And there's also data that patients with limited stage disease who have an excellent response to first-line therapy also may not have a benefit to PCI. And it also really comes down to the values of the patient, shared decision-making, weighing the risks of cognitive function versus their desire to have more complete disease control. And then also thinking about whether patients will be able to adhere to a close MRI surveillance protocol. So all that together, just to say we don't really know the answer yet, but it just comes down to each individual patient. That's all I got. Any questions? Yep.
What site is the NRG 60
I don't know. It's not open, as far as I know, in Louisiana.
I've heard that the clinical trials are currently trying to open it, but that's just a discussion.
Good question, yeah.
For whole brain radiation, at what point would you consider that for patients not prophylactically, but as treatment instead of SRS?
It's really difficult. So I think Dr. Keene alluded to the fact that we're kind of pushing the envelope on number of brain metastases to treat with SRS. And I don't really have any kind of strict upper limit. I think if it's like probably like 30 is the most that I've ever seen treated, maybe up to 35. But it depends on sort of like their disease progress, like how controlled is their extracranial disease, what's their performance status, what's the distribution of the brain metastases, are you able to spare normal brain tissue in between? So it's very individualized, but I don't really have any strict cutoff. Thanks so much.
All right, well, we finished a bit early, so thank you everyone for coming to listen to our neuro-oncology lectures. I learned a lot. I hope that you all did too. Thank you to all of our speakers, not only for speaking at this conference and educating all of us, but with how multidisciplinary neuro-oncology is, I couldn't do my job without any of you. So personally, I appreciate it. And I hope everyone had a great time and enjoy the rest of the conference.
That was a curiosity.
No, probably not. Yeah, you have to answer it somewhere from outside. And it's just, yeah, that'd be hard to contain for this. How big would it? The smallest ones are probably about that. We use a more small one. Entrance of the tube is big. Was that hardly many? You must have a very steady hands. Yeah, you'd be surprised. People that train these in have very steady hands. You just have to compensate with this. I'll be nervous. That is not as dangerous as you put something on it. Yeah, I can imagine. That's a long time ago. You miss that at all? Yeah, but sometime, but passing that. Yeah. Great. Because sometimes, not frequently, but sometimes it's weird, you know, and I hate to, sometimes I hate to say, yeah. But it's like guessing, you know, like, this is. Well, give me more. And we kind of do this, the fetal biopsies. So take the biopsy samples, but maybe she just puts a tube into it and takes your chunks. That the sample he remember, tell him this is a yeah, but without that biopsy, the patient doesn't have a no, I think it's, we just, if it looks like this is all going to do a biopsy, we just figure out, but I don't think we think of taking a good sample. So, yeah, because, right, because, yeah. We've actually had several cases recently. Yeah. Even you were like, this one's high grade, and vice versa. All these names, that's almost everything.
I
I don't care where you put my sign. They can be across the unit, I just need to move it. It was like, give me the ones that are crashing, because I still don't have to talk to them. I can fix it. Right, I will do all the other things. And just, and sometimes that makes sense also. You know, like, or just like, that used to make me crazy too, because I'd be like, look, like, you don't get to treat me like this, like, because I work, I'm the nurse for you right now. You don't get to just like order me around and be demanding and all this stuff. Yeah, that's not what I do. That's not why I'm not here. Right. You're not paying me for work today. So I just, it is making me crazy. Right. Oh, sorry. He needs to, that's fine too. Did you know? Like when they kept saying that yesterday, I was just like, no, now is not a good time. You need to pop off at the next person that brings this money away. He has an MRI this week, but his visit is not till like the following week. And I said, yeah. Well, I told him, I said, we can like, well, I can like maybe make a visit. Is what I think that's what I told him. So we can make a visit. I don't think he needs that. I think, yeah, we can put a visit. I think I'll put a visit. Oh. Gosh. Well then, yeah, maybe that is good. I'll tell James to see where he can fit in. I don't know what day is that. I can't remember what day is that. But I was like, so look, that's fine. I think it's fine. We can get help with that also. You know, and he's been like lately in virtual. And he's not too. I guess not. Feel as stressed and like the waiting is different too. I feel like if we're a few minutes late on a virtual, then a few minutes on home, you know, versus like having to sit in the clinic and be like, right. I'd rather have, I'd be like, oh my gosh, that was connection. Disconnected. Oh, sorry. You're gonna yell at me, oh, sorry, yeah. Sorry, oh my goodness, I don't know what happened. I'll call you back. All right, I'm sorry. But yeah, I can tell. I think I thought to do it the other day. I think I've been. And I was like, I might put it in next week. So I'll just follow. Oh no. I'm so bad at that. So like that's why I was like, I usually it takes me a long time. I know it's terrible, but I mean, I'm sure I don't feel like it wasn't a fever. I feel like that week. You're right. Yeah. Right. And he was like, so it's so hard when the little ones are having issues because if like music, right? Like it's like, and so like when I know for me, like what I try to do with my kids, because I think they all have. I try to give them like the expectorant, all day, so that if like if you haven't really been out that because and then give them the one like this lesson at night so they can sleep a little bit. But like my oldest kid, he got pneumonia after a like respiratory infection. And I think it was my fault because I was suppressing. I just was giving him like cough suppressant and not giving him like an expectorant, and I think he just wasn't coughing enough. So, it's my fault, and I don't know why I would not have that would have gone. But so like after that, would like, and then she would spit it out, like right after it got, yeah. So we had to do that a lot because she was like refusing, like, or which also really right. But those, if you have to run out, those are, if he has fever, I found those. I mean, like seeing their eyes and all, it's just, I'm wondering if like, if you think of, you definitely have like,
To be honest, I haven't. It was a little harder for me because our parents are so right there. I had to take care of
I've walked through every room. He's not in general. He's not, and I'm like, gastrointestinal, here you are. Have a seat. Fuck yeah. I'm gonna get my crew up. I know, yeah, they're all so happy.
What if there's a pointer? Is this a pointer? Okay, guys, good afternoon. Thank you for joining us on this Friday afternoon for the HPB session. We're super excited. We have a little bit of a format change today. My name is John Lyons. I'm a surgical oncologist. I work in Baton Rouge, and they've asked me to talk on hepatocellular cancer today, so I'm going to get to that in a second. We have two additional speakers, and we had a third speaker who's unfortunately not able to be here. So Randy Cannell is going to be our panel discussant today, so we're going to change it up a little bit, but we hope it's still interesting and useful for everybody. I'm a surgical oncologist. I do general surgical oncology, but in the world of surg-onc, I focus on liver, pancreas, skin, and soft tissue. So I've been asked to speak today about hepatocellular cancer, screening and the road to early detection. As everybody in this room knows, cancer screening saves lives. These are the data from cervical cancer. Over the past 40 years, as the Pap smear has become more prevalent, the cervical cancer incident rate has fallen, as has the cervical cancer death rate. Colon cancer, similarly. The red line illustrates the screening rate, and as the screening rate has gone up over the past 25 years, the mortality rate from colon cancer has diminished. Similarly, breast cancer and prostate cancer over the last 30 years or so, as we have improved and increased our screening modalities for breast and prostate cancer, the mortality rates for these two malignancies have similarly fallen. The way we assess the success of a screening tool is called the mortality rate ratio. And it sounds really complicated, but it's actually pretty simple. A randomized trial is conducted, and they look at the mortality in the screening arm compared to the mortality in the control arm. And so that ratio is what's assessed. It should be less than 1. And this is the rate ratios of the various cancers for which we have screening. So an adequate number would be somewhere between 0.7 and 0.8, something like that. So where is liver cancer? Where is liver cancer on this? Well, there is data to support screening for liver cancer, and we have a randomized trial that was conducted looking at screening in liver cancer. There's only one to date, so it's an important trial because of that, but this is what most of our data is based on. 18,000 patients diagnosed in Shanghai with chronic hepatitis B. They were randomized to have, 9,000 of them were randomized to have either ultrasound AFP, which is our standard screening modalities, versus no screening at all. The primary outcome was standardized mortality from HCC. This is the data. So in this line up here, this is incidence on the y-axis. On this line here is screening, so no surprise that at every time point you have a higher incidence of, you're picking up more cancers because you're screening them, so the incidence is higher in the screening arm. But this is where it gets interesting. So screening is over here, control is over here, and in the screening group you have about 60% of patients diagnosed with early stage disease, stage 1 disease, 0% of patients in the control group. Clearly, it's effective. And similarly, if you look here, the treatment, liver-directed treatment, about 80% of patients versus about 50% of patients in the control group. And where the rubber meets the road down here is the 5-year survival. So you have about a 46% 5-year survival in the screening group from HCC related to 0% in the control group. And if we get back to that number I was quoting a minute ago, the rate ratio, the rate ratio is illustrated here, and it's 0.63. So if I bring you back to the initial slide showing the effectiveness of cancer screening with all of these rate ratios, liver cancer is right in there. So clearly we have data to suggest that liver cancer screening is valuable and should be done. But the problem with it is this is a single randomized trial. It's old. It was done 20 years ago. It was in a Chinese population, and the patients didn't have cirrhosis. They had chronic hepatitis B. So the argument is this really generalizable to a Western population? So I have some additional data for you. Multiple single-arm prospective studies have been conducted looking at screening throughout the world, in the West and in the East. This is a meta-analysis looking at over 30 studies looking at the relationship between screening and HCC outcomes. So this is a meta-analysis, so the forest plot here, but I'll point your attention down here to the bottom. So the pooled odds ratio for early detection in the screening arm was twofold higher, so suggesting that patients who were screened have a twofold likelihood of being detected at an earlier rate than those who just were observed. Similarly, this is the curative treatment rate, again, about a twofold increase in the curative treatment rate amongst patients who were screened. And when we talk about survival, about a 1.9-fold increase in 3-year survival amongst patients who were screened. So again, this is the data that we have supporting screening for liver cancer. But why do we care about liver cancer? I mean, what's the big deal, right? It's not as prevalent as lung cancer or prevalent as breast cancer. Well, I think we should care about it for a few reasons. HCC remains the fastest growing cause of cancer death in the United States. Most patients, as I showed you in that randomized trial, do present at late stages, and when they present at late stages, as we all know, our options for treatment and our cure rates are extremely limited. If you live in Louisiana, and I suspect a lot of you guys do, it really hits closer to home because this is the mortality data for the country, okay? And red is bad. Louisiana's red, and that's bad. And this isn't a political statement. This is just a color associated with mortality. And if you look at the table here, we're second, at least at this time, and we're still top 10 in liver cancer mortality. So it's a major problem. It remains a major public health problem, and it's not going away. When you look at screening, you always have to ask the question, is it cost effective, okay? And because obviously we've shown that it's effective, but is it cost effective? The way we do that is we assess the quality adjusted life years, and that's what this graph shows, okay? So what these researchers did is they looked at no surveillance versus ultrasound with AFP, and they assessed the cost per quality adjusted life year based on the incidence of HCC. And they found that the curves separated and that the screening with AFP and ultrasound became cost-effective when the incidence of HCC was 0.4%. So what does that mean? That means for average individuals, it's probably not cost-effective. That's why we don't screen the entire population. But when your incidence is 0.4% or greater, then it makes sense to do it. Patients with cirrhosis typically have a incidence of HCC development of about 1 to 2%. That's an early stage. It obviously depends on the severity of the cirrhosis and the etiology of cirrhosis, but at a minimum, when you read about the incidence of HCC with cirrhosis, it's at least 1 to 2%. So my point is, living here, you definitely have a cost-effective screening. So I think this demonstrates not only effectiveness, but also cost-effectiveness. Currently, these are all the organizations that recommend screening guidelines, that have some sort of screening guidelines for liver cancer. And all the American GI associations, all of the major American cancer associations all have screening guidelines, with the exception of USPSTF. And we'll talk about that in a minute. But the Asian societies, the European societies, all recommend screening for liver cancer. And these are the people who NCCN says we should screen: cirrhosis from any etiology and chronic hepatitis B. Most of you all know this, but just as a reminder, liver cancer screening is recommended to be done with an ultrasound and an AFP. Okay, the AFP is a little bit debatable, but the sensitivity is higher when you add the two tests versus doing one alone, and it's recommended to be done every 6 months. But the screening rates are low. It's not like breast cancer or colon cancer where it gets a lot of attention. This was a study that was at UT Southwestern about 15 years ago, looking at national data and assessing the rate of screening. They found that consistent screening was only in about 18%, and that number really hasn't changed. If you read about it in 2025, it's still about 20-25%. It's not very high, and it's even lower in areas like Louisiana. So there are barriers, right? Why is that? Well, there are barriers to the test, okay? So you've got ultrasound, you've got problems with ultrasound and AFP, okay? So in the case of ultrasound, it is a low sensitivity test for early stage HCC. It's hard to see small lesions, especially when the morphology of the liver is cirrhotic. It's operator dependent. It can be less reliable in obesity, and that's significant because obesity is becoming the major etiology of HCC. It's overcoming viral hepatitis. And then AFP is also limited, right? So you can see the sensitivity, the specificity is quite good, but the sensitivity decreases as the AFP as the threshold increases. There are also patient and provider-related barriers, and you guys are aware of all of these, right? So patients may have lack of awareness. They may not know that they're cirrhotic. They may not be aware of the relationship between cirrhosis and HCC. There's the lack of transportation. There's the lack of knowledge. There's healthcare literacy. Provider-related issues have to do with decision fatigue. The data demonstrates that you're more likely to receive a screening test if you see the doctor earlier in the day, or you see the provider earlier in the day, or if you have fewer problem list diagnoses. If you have a smaller list of problems on your list and less decisions the provider has to make, you're more likely to get a screening test ordered. That's the data. Many people forget to order the test as a result of this. And then obviously there's the underdiagnosis of cirrhosis. And then there's no USPSTF recs. So those are all challenges. We usually use that as the industry standard to guide screening guidelines. And we don't have that in liver cancer. So that's a major challenge barrier to why liver cancer screening, at least I think why liver cancer screening is not done enough. There are success stories, okay? So in the United States and California, there was a big mail outreach program where a health system sent mailers to individuals with fibrosis scores of 3 or 4 to encourage them to get HCC screening. And then if they didn't answer the mailer, they had nurse navigators contact them. So this is a cumbersome project, but they did increase their screening rates from 30% to 50%, okay? So it can be done. A province in Australia had a similar study that showed improvements as well. In Germany, there was a major move to identify individuals with cirrhosis, and so they encouraged providers to look for platelet levels and to look for AST and ALT, and they identified cirrhosis at a higher level. This has not been validated to show an improvement in HCC detection, but it's a step in the right direction. The United States Veterans Administration, and there was also a national movement, similar concepts, both worked on provider education, reminders of the association and the importance of HCC screening, and then national movements. There have been a couple of success stories, both in Japan and in Thailand, where individuals have been encouraged to have screening done for viral hepatitis and to get screening for HCC. But you know, these are countries that put an entire initiative behind this because they feel like it's important, and they also have national health care where patients are not charged. They have easier access, and these tests are free of charge. So I don't know if it's really comparable to our healthcare system, but these are success stories. This is data that I looked at in our neighborhood in Baton Rouge. I work at FMOL, Franciscan Missionaries of Our Lady, and I wanted to see what our numbers were. So this was a slicer dicer. Y'all have Epic, y'all are familiar with a slicer dicer. And so in green here is the number of patients who had an encounter and a problemless diagnosis of cirrhosis. So in 2021, there were 3,700 patients. Of those 3,700 patients, there were only 273 that had ultrasounds. Now, it's possible that they had an ultrasound ordered by somebody else, but in our system, that's a pretty dismal rate, 7.3%. That's way less than that UT Southwestern study that showed a 20% rate. So that bothered me, and so with that information, I said, well, let's do a QI initiative. So what I wanted to do, and what we did, is we built a reminder and an automated order set into Epic to encourage providers to order screening ultrasounds on patients with cirrhosis. So it's an idea of using the EMR for good. I know it's been such a challenge for many people to navigate the EMR, but this may be something that would be a promising good thing that could come out of using the EMR. So first we went to radiology, and I said, look, if we order a bunch more ultrasounds on these 3,100 patients, can you absorb this? Will you be able to do it? And they said, yeah, we can do it. I said, okay, great. So then I went to the quality department for the health system, and I said, this is what I want to do. And they said, yeah, we like it. We'll support this. And so then they directed me to the Health Leaders Network. The Health Leaders Network is the group that's sort of responsible for the metrics that the primary care physicians are supposed to hit. And so I had to get buy-in from them because that's who we want to order the test. And so they supported it. So you can see this was quite a cumbersome list of folks. And then once we had approval from those, then I went to IT and said, can you build it? What would it look like? And they said, yeah, I think we can. And then they directed me to the Epic gurus. And so the Epic folks then did a build out. So, and during the process, this was something that was discussed with, the GI physicians, not only the primary care docs, but the GI physicians, obviously the radiologists, the cancer specialists in the system, in order to get buy-in from everybody. And so currently, this is what it looks like. And I know this is kind of small, but this is what, if you can see, if they have a problem-less diagnosis of cirrhosis, then there's a reminder that pops up on the dashboard that says liver cancer screening is needed. And then you can see down here, you have the option to check this. This is an opt-in program. It's not mandatory. If the provider doesn't think it's appropriate, they don't need to select it. But it's just a reminder. It's a best practice advisory is what it's called in Epic, a BPA. And these are your options. So you come down here and you can choose AFP, you can choose ultrasound, and that's how we do it. So let me summarize. I got a few more things to speak, but I'm just going to stop and summarize for a second. HCC remains a major source of cancer mortality. The mortality rates are rising. It's the fastest cause of cancer mortality in the United States currently. The screening is not perfect. There are major problems with it, but it does reduce mortality. I think we've demonstrated that, and it is cost effective. Despite this, the screening rates remain low in the United States for multiple reasons. One major reason is we don't have USPSTF backing on it. But the future offers multiple possibilities for improvement. So I'm gonna close this out by talking about a few potential areas for growth and where we might see improvement in this. So there are some, I wrote GALAD, but this refers to some clinical risk scores that exist that are other than just AFP and ultrasound. So GALAD is one of many such clinical risk scores that incorporate additional biomarkers and sort of history, if you will, to better personalize someone's risk of HCC when they have cirrhosis. GALAD stands for gender, age, AFP, L3, and then DEP, which is another prothrombin biomarker. So that's one option. Another option is different radiological techniques. So abbreviated MRI is being considered, something called contrast-enhanced ultrasound, the possibility of using AI to improve radiomics, so radiologists could identify smaller lesions in the field of a cirrhotic liver is also being considered. So those are all areas of study. And then obviously the most exciting thing is the concept of a liquid biopsy, right? Many of the folks who represent liquid biopsies are in this room, so you all are quite familiar with this concept of taking a vial of blood and looking at nucleic acid and assessing the risk of malignancy based on the DNA or RNA profile within the vial of blood. But there are many ways that can be done, and I'll briefly run through that. This is a study that is actively enrolling patients. This is PI'd through UT Southwestern, and they are looking at the GALAD score, basically. And again, GALAD looks at gender, age, AFP, L3, AFP, and DCP, which is a prothrombin marker, and comparing the GALAD score to annual ultrasound and AFP, semi-annual AFP and ultrasound. And the primary endpoint would be reducing the proportion of late-stage HCC. They're attempting to enroll 5,000 patients. This is another study that's enrolling patients currently in the Veterans Administration. The goal is to accrue 5,000 veterans with early-stage compensated cirrhosis, and they're going to randomize them to have either AFP with abbreviated MRI, which is a quicker version of the MRI with fewer series, supposedly only takes 15 minutes, and comparing this group of patients to standard AFP ultrasound every 6 months. And the primary outcome would be HCC mortality. And then liquid biopsies, again, this is the way we assess nucleic acid within the bloodstream. There are many ways that this can be done: cell-free DNA, circulating tumor DNA, cancer cells, exosomes. And this table is very busy, but it basically talks about all of the strengths and the weaknesses and the potential clinical applications and the studies that have been done. To date, there are there's some promising tests that are emerging, but there's not one that is really head and shoulders above the other one. So it sort of remains to be seen. But this was a study that was, this probably holds the most promise in looking at circulating tumor DNA methylation. And I just point, this was a study out of China a few years ago, but the sensitivity over here, if you look at the sensitivity rates of AFP alone, 30%, ultrasound alone, 50 to 70%, AFP plus ultrasound, now you're talking about 80%, but when you add the circulating tumor DNA, it brings it up to 100%. So it may be that these modalities all exist together. We're not quite sure, but I think this offers potential promise for HCC screening as we move forward, because I think this is really going to be impactful for this group of individuals. So I think that's it. The future offers multiple possible areas for improvement. I would like to thank you for your attention, and I'm happy to answer any questions. I got Ms. Pam and then Dr. Sachs. Yes, ma'am.
So, when did you implement your BPA screening for HCC? Have you seen that?
That's a good question. The answer is about a year and a half ago, about 18 months ago. And the results have not been, we moved the needle from a use of the BPA from like 1% to 2%. And the IT guys thought that was great. That wasn't really what I was hoping for, so I'm hoping for more buy-in. So it has not been used to the extent that I thought it would be used. So that's where we are. But it's a work in progress. Yes, sir.
So part of my practice is hematology.
Yeah.
And I get a lot of referrals for low platelets. And I am often the person that tells them they have cirrhosis. I usually order, as part of the workup for low platelets, an abdominal ultrasound. Do I need anything special looking at the liver, or?
No, it's a routine ultrasound. If you write liver screening, they ought to have a protocol to look for it, and you should add an AFP. That's a little bit debated. But like I was showing, the data indicates that it's more sensitive when you add the AFP to it, but I think that's it.
So the radiologists, ultrasonographers, hedge, like nodular, focal, steatosis or something.
Right.
They're trying to hedge and cover their ass on a scan.
Yeah.
And so once they see that, who am I sending them to? I mean, I'll get the AFP. Am I sending them back to GI? Am I sending them to you?
Well, I mean, I think the next step would be cross-sectional imaging.
So go to CT.
CT or MRI, yeah, CT or with and without contrast, liver protocol, saw something on the MRI, needs additional clarification. And then, it depends. If you've got a good GI doc who wants to embrace these, I think that'd be fine, alternatively.
And it's not really screening.
Yeah.
I mean, I'm seeing them for a different problem.
Right, that's right.
Some of them are at high risk and they're not being screened.
Well, if they're truly cirrhotic, then that would be, screening for liver cancer, but so you're screening them, even though they've got a different malignancy, you're screening them for something separate. But the algorithm goes, if you see something on the ultrasound, cross-sectional imaging is next. And whether you get an AFP, if you get a CT liver protocol or an MRI, you could split hairs there, but you want to get one of those. Yeah.
I think your patient's problem is they have a undiagnosed cirrhosis, so I think once the ultrasound picks that up, they should be referred to hepatology to do such.
Hepatologist, you inform me.
Yeah, I was going to say, if you're in an institution with hepatology, then but right, on the North Shore, I know that they're few and far between, and on where I am in Baton Rouge, they're
Listed on the consent agenda.
So, any other questions? All right. Well, thank you. I have the pleasure of introducing the next speaker, Where are your slides, doctor?
Let me see. Yeah, this one, I think.
Is that you? Yeah? Okay, wonderful. All right. Dr. Lingling Du specializes in medical oncology at the Ochsner MD Anderson Cancer Center. She earned her medical degree from Peking University Health Center in China. She completed her internship and residency at the Cleveland Clinic Foundation. She completed fellowship in hematology oncology at WashU in St. Louis. She specializes in hematology oncology with a special interest in GI cancers, and also specializes in GI neuroendocrine tumors and rare types of tumors. She's board certified in internal medicine, hematology, oncology, and we're very lucky to have her today to be speaking about novel targeted therapy for biliary tract cancers. Thank you, Dr. Du.
Good afternoon, everyone. Thank you so much for your time here. I'm a GI medical oncologist, so today I'm going to discuss novel targeted therapy for biliary tract cancers. Actually, it's one of the most exciting area right now. Here's my disclosure. Just a little bit of background. Advanced biliary tract cancer is a disease that is still, after all these years and decades, with very poor prognosis. It's almost as bad as advanced pancreatic cancer. In 2026, there's an estimated of 12,640 new cases and 4,590 deaths from it. So definitely a disease with very high mortality rate. Just for the overall patient population with advanced biliary tract cancer, what are we looking at? We're looking at, for these patients with our best frontline chemo-immunotherapy combination, a median overall survival of 12.8 months. So a little bit over a year, and a response rate of 27%. How about second line after they progress on frontline treatment? With the ABC trial showing that the standard of care second line is FOLFOX, guess what the prognosis is with FOLFOX, median overall survival 6.2 months, with the second line treatment with a response rate of 5%. That's with second line. So definitely a disease with very, very grim prognosis. Fortunately, right now we find out that there are actually more and more targets with biliary tract cancers that we have targeted therapy for. And it's important to point out that for biliary tract cancer, although we all call them BTC or cholangiocarcinoma, it's actually a very heterogeneous group of disease. There's intrahepatic cholangiocarcinoma that starts from the bile ducts inside of the liver. There's extrahepatic cholangiocarcinoma that starts from bile duct outside of the liver. And there's also gallbladder cancer. Usually we think it's probably even more malignant than the other two. And then right now we have a lot of targets that we can potentially target. HER2 expression is definitely one of the largest targets that we have for biliary tract cancer. Some reports that gallbladder cancer may be more enriched with HER2 amplification. And then intrahepatic cholangiocarcinoma, they may be more enriched with FGFR2 fusion or alteration or IDH1 mutation. And in addition, we have BRAF V600E, we have rarely KRAS G12C, and rare mutations of NTRK fusion or RET mutation. And then we're going to go through all the targets and associated target therapy in the frequency of more common and go all the way down to less common. So first, HER2, probably our biggest target in biliary tract cancer. Depends on the literature. Some literature reports that up to 20% of biliary tract cancer are HER2 positive, and it's actually more common in patients with gallbladder cancer. We actually have a couple of regimens that we can use for patients with HER2 positive biliary tract cancer. One of them is a combination of a TKI and an antibody, tucatinib and trastuzumab. Tucatinib is an oral TKI that targets HER2. It works here intracellularly, and trastuzumab, we've been using it for like 30 years for breast cancer. It's a monoclonal antibody that targets the extracellular domain of HER2, so it works here. So one works here, one works here. In the phase 2 basket study, tucatinib combined with trastuzumab was tested in patients with HER2 positive advanced biliary tract cancer in the second line or beyond setting. Important to point out that in order to be eligible for the study, patient needs to have received no prior HER2 directed therapy, so HER2 naive. And like the majority of phase 2 study, the primary endpoint is response rate. let's see how it works. One thing I really like about this publication is they actually outline for each patient how did they find out the patient has HER2-positive disease. It's actually very important for our clinical practice. We can see that in some patients, they did IHC on the tumor. If the 3+, it's HER2-positive. If it's 2+, they reflex to FISH, and positive means that they're HER2-positive. Also, there are also a lot of patients that did not do the IHC, but they did NGS, either tissue or blood, and that's how they found out patients are HER2-positive. I really think that this is what we should be doing. At Ochsner, when patients are diagnosed with biliary tract cancer, actually they all reflex to IHC testing, and when they have advanced disease, we'll do NGS and try not to miss any patient that with a possible target for us to use. And we can see for all the patients that are HER2-positive, received tucatinib and trastuzumab, the overall response rate was 46%. And remember, for all the other patients, the response rate with second-line treatment was 5%, so this is amazing. And looking at all patients, the median progression-free survival is about 5 months or so, and the median overall survival was 15.5 months, which looks way much better compared to like 6 months with FOLFOX alone. And then another very promising drug that we're actually using right now is zanidatamab. It works differently. It's a bispecific monoclonal antibody that directly directed against 2 different domains of HER2. So here and here, targets 2 domains. It's a special drug. In the Horizon BTC-01 study, it's a phase 2 study that used zanidatamab in patients with advanced biliary tract cancer in the second-line or beyond setting. This trial, they have 2 cohorts. Cohort 1 is patients with HER2-positive, like IHC 2+ or 3+, and cohort 2 are IHC 0 or 1 positive, so basically not really HER2-positive patients. And the primary endpoint is looking at overall response rate for cohort 1. And if we would look at their results, for all patients in cohort 1, like HER2-positive, they observe a response rate of 41%, again, pretty high. Disease control rate 69%, so almost 70%, and the median progression-free survival was 5.5 months. But if you dive deeper into the data, you see that actually the response was seen in patients with IHC 3+, so true HER2-positive disease. They see a response rate of 52%, disease control rate 79%, so close to 80%, and the median progression-free survival 7.2 months. Regarding overall survival, looking at all patient median overall survival was 15.5 months, but we can see that patients with IHC 3+ clearly did better. Median OS was 18 months, compared to 2+ was only at 5.2 months. So based on, right now, zanidatamab, we can use it in the second-line setting, and right now there's a phase 3, Horizon BTC-302 first-line trial is ongoing. Basically, they enroll patients with advanced HER2-positive biliary tract cancer. They randomize patient to the experimental arm, which combines zanidatamab with chemoimmunotherapy versus the control arm, which is standard of care chemoimmunotherapy. And this trial is currently ongoing, and we also have this trial open at Ochsner as well, and actively enrolling patients. And the other big player in the HER2 market is the trastuzumab deruxtecan. We call it TDXD. It works differently. It's an antibody-drug conjugate consisting of an anti-HER2 monoclonal antibody that covalently linked to a topoisomerase 1 inhibitor cytotoxic payload. So when we give this medication, the antibody will get hooked up with HER2 protein and then got internalized into the tumor cells, leading to payload release. And after payload release, the topoisomerase 1 inhibitor will kill the cancer, leading to cancer cell death. And also there's penetration of released payload to neighbors, hopefully to kill neighboring effect to kill the neighboring cancer cells as well. In the basket trial, the Destiny Pan-Tumor02 phase 2 study, they give all patients with HER2-expressing solid tumors TDXD at 5.4 mg/kg every 3 weeks. All patients have HER2-positive disease, locally advanced or metastatic solid tumors, have received at least 1 prior systemic treatment. They actually, the interesting part is they do allow prior HER2-directed therapy. So this is different from other anti-HER2 regimen. And primary endpoint is response rate. If we look at the biliary tract cohort, there was a total of 41 patients with HER2-positive biliary tract cancer. We can see that the efficacy is really being observed in patients with HER2-3+ disease. So in HER2-3+, response rate was 56.3%, and the median progression-free survival in HER2-3+ was 7.4 months, and the median overall survival in HER2-3+ patient population was 12.4 months. Around the same time, there's another phase 2 study in Japan that they used T-DXd same dose in patients with HER2-positive biliary tract cancer. And they actually enroll patients with HER2-positive or HER2-low, because T-DXd in breast cancer, it also works in HER2-low disease as well. Same treatment, T-DXd 5.4 mg per kg every 3 weeks. In the second-line setting, allow prior anti-HER2 regimen, and primary endpoint is response rate. It's a very small study. A total of 30 patients received treatment. 22 of them had HER2-positive disease, and in the HER2-positive group, response rate 36%, median progression-free survival 5 months, median overall survival 7.1 months. But again, it's a very small study, but we do have data to support the use of T-DXd in patients with HER2-positive biliary tract cancer. And then the last one that we're going to talk about, the HER2 targeted therapy, is a chemo-free regimen, trastuzumab plus pertuzumab, which is a regimen that we've also been using for a long time in treating patients with breast cancer. Pertuzumab is a monoclonal antibody binding to extracellular subdomain 2 of HER2, inhibiting HER2 dimerization. So pertuzumab worked here, and trastuzumab worked here. In a phase 2 TAPPER basket trial, they enrolled a total of 29 patients with biliary tract cancer with ERVB2 or 3 alterations, response rate 32%, median progression-free survival 11 weeks, median overall survival 30 weeks. So this is also on the NCCN guideline to treat patients with HER2-positive biliary tract cancer. In summary, we have several players for patients with HER2-positive disease. Tucatinib trastuzumab combination, response rate 46.7%, progression-free survival 5.5 months, median overall survival 15.5 months. Zanidatamab single agent in patients with IHC 3+ HER2-positive disease, response rate 52%, median progression-free survival 7.2 months, median overall survival 18.1 months. T-DXd trastuzumab deruxtecan in IHC 3+ disease, response rate 56%, median progression-free survival 7.4 months, and median overall survival 12.4 months. And lastly, chemo-free regimen, trastuzumab plus pertuzumab, response rate 32%, median progression-free survival 2.7 months, and median overall survival 7.5 months. It's also important to point out for trastuzumab deruxtecan, it actually can be used even after a patient has received prior anti-HER2 regimen. Then going down our list, the next one we're going to discuss is the FGFR2 fusion, which actually in intrahepatic cholangiocarcinoma, FGFR2 gene alteration was observed in 10 to 16% of patients with intrahepatic cholangiocarcinoma. So we definitely see it. I also have patients with FGFR2 fusion positive cholangiocarcinoma as well. We also have several players in the market. Pamigatinib is one of the first drugs that we know. It's a pan-FGFR inhibitor, inhibits FGFR1 through 3. In the phase 2 5202 trial, it's a single-arm study using pamigatinib in patients with FGFR-positive biliary tract cancer in the second-line and beyond setting. A total of 3 cohorts. The first cohort is really the target, FGFR2 fusions or rearrangement positive, and then cohort 2 is other FGFR alterations, and cohort 3 is no FGFR alterations. Of course, primary endpoint is looking at response rate in the targeted patient population, cohort 1. So what's their result for cohort 1? They see patients a response rate of 35.5%, median progression-free survival close to 7 months, and median overall survival 21 months. Again, we're talking about for all the other patients, second-line median overall survival 6 months. So this is almost 2 years, which looks pretty good. For all the pan-FGFR inhibitors, when we give it to patients, we do need to think about the most common side effect that almost everybody has is hyperphosphatemia. The phosphorus level come up really high, so it's not like you give people the drug, you see them in a month and recheck the phosphorus level. When I give patients this group of medication, I actually check phosphorus level every 3 to 4 days, and you can see the phosphorus levels start coming up very rapidly. Several years ago, there's a phase 3 FIGHT-302 study, first-line trial combining pemigatinib with cisplatin gemcitabine, that trying to see moving it to the frontline setting would it benefit patient. However, this trial was close to accrual back in 2024 because there's a change in the standard of care frontline treatment. And the other drug that I use a lot is futibatinib. Futibatinib is an FGFR1 to 4 inhibitor, so again, pan-FGFR inhibitor. In the phase 2 Phoenix CCA2 trial, again, very similar design, single arm, used in second line and beyond setting, primary endpoint response rate, and they observe a response rate of 42%, median progression-free survival 9 months, and median overall survival 21.7 months. Most common side effects, similarly, hyperphosphatemia. We monitor patients very, very closely. And again, similarly, several years ago, there's this phase 3 frontline study combining futibatinib with cisplatin gemcitabine in frontline setting. They also stopped to accrual about 2 years ago. And the third one that we have good data on is erdafitinib. Erdafitinib, I personally used it over 10 years ago for patients with FGFR positive bladder cancer, so it has other indications as well. It's a pan-FGFR inhibitor. In the phase 2 RETINA study, they used erdafitinib for patients with advanced solid tumors with FGFR alterations. A total of 217 patients, primary endpoint is response rate. Out of them, 31 patients had cholangiocarcinoma, and regarding the efficacy in cholangio cohort, response rate was 52%, disease control rate 97%, so disease control is actually quite high. And similarly, it caused hyperphosphatemia, stomatitis, diarrhea. For all patients, they reported median progression-free survival of 4 months and median overall survival 10 months. But later this year, they actually have a newer publication that reported they pulled all the 2 large trials that tested erdafitinib in patients with FGFR-positive cholangiocarcinoma, and they found that very similar response rate, disease control rate, and median progression-free survival 6.9 months and median overall survival 18 months. So erdafitinib is also on the NCCN guideline recommended for patients with FGFR2 fusion positive cholangiocarcinoma. And most recently at ASCO GI this year, like all the other we talked about was pan-FGFR inhibitor. At ASCO GI this year, they reported the efficacy on lirafugratinib, which is a different highly selective FGFR2 inhibitor, and they tested in patients in the second line setting for FGFR2 fusion positive cholangiocarcinoma. And their efficacy data is quite impressive. The overall response rate was 46.5%, disease control rate 96.5%, median progression-free survival was close to a year at 11 months, and median overall survival was 22.8 months. So definitely very good efficacy data. And if we look at the waterfall plot, remember disease control is 96%, so almost all patients had a certain degree of tumor shrinkage. It looks very nice. And because it's selective FGFR2 inhibitor, it sounds like the toxicity profile is a little bit different compared to other pan-FGFR inhibitors. Like the other pan-FGFR inhibitors, we really worry about hyperphosphatemia. For this one, not that many hyperphosphatemia, but seems to be different side effect. Like more people have stomatitis, Hanford syndrome, nail toxicity, and some people have retinal pigment epithelial detachment. That is not FDA approved yet, but it's very exciting data that they just reported at ASCO GI. So in summary, right now for FGFR inhibitors for biliary tract cancer, we have 4 that we have good data on. Pemigatinib, pan-FGFR inhibitor, response rate 35%, progression-free survival 6.9, median OS 21 months. Futibatinib, response rate 42%, median PFS 9 months, median overall survival 21.7 months. Erdafitinib, response rate 52%. For all solid tumor, median PFS 4.2, median OS 10.7, but for the cholangio, when they group all patients together, it's even better. And lirafugratinib, which is a newer medication that they just reported, selective FGFR2 inhibitor, response rate 46%, median progression-free survival 11.3 months, and median overall survival, again, close to 2 years, 22.8 months. And next, we're going to discuss a very special mutation, IDH1 mutation, which was observed in 13% of intrahepatic and 1% of extrahepatic cholangiocarcinoma. We do have an IDH1 inhibitor, avocitinib, in the phase 3 Clarity trial. They enroll patients with pretreated cholangiocarcinoma with IDH1 mutation, randomized to receive avocitinib versus placebo. They allow crossover at time of progression, and primary endpoints progression-free survival. Response rate was low, 2% with avocitinib, median progression-free survival 2.7 months versus 1.4 months with placebo. But after adjustment for crossover, they reported median overall survival of 10.3 months versus 5.1 months with placebo. So if our patient have an IDH1 mutation, definitely we should use avocitinib in their treatment course. And next, we're going to talk about a mutation that all GI oncologists are very familiar with, BRAF V E mutation. It's less common in biliary tract cancer. 5 to 7% of patients have BRAF V E mutation. We do have a combination that has tumor-agnostic indication. Dabrafenib plus trametinib. Dabrafenib is a BRAF inhibitor, and trametinib is a MEK inhibitor. In the phase 2 ROLL study, they used dabrafenib plus trametinib in all patients with BRAF V mutated, all solid tumors. Primary endpoint is response rate. A total of 43 biliary tract cancer patients. Response rate was pretty high, 53%, with a median progression-free survival 7.5 months and median overall survival 13.5 months. And next, we're going to discuss a even more rare side effect, KRAS G12C mutation, which was only seen in 1% of patients with biliary tract cancer. We know that for pancreatic cancer, almost 90% of patients had some sort of KRAS mutations, right? But for bile duct cancer, it's actually less common. KRAS mutations probably seen in about 20 to 30% of patients. Extrahepatic cholangiocarcinoma, they may have more KRAS mutation, but it's less common in gallbladder cancer, intrahepatic cholangiocarcinoma. KRAS G12C mutation is very rare at 1%. Adagrasib is a KRAS G12C inhibitor. In the phase 2 CRYSTAL-1 study, they enroll all patients with KRAS G12C mutated advanced solid tumors and give them adagrasib, 600 milligram 2 times daily by mouth. Overall response rate is their primary endpoint. A total of 12 patients with biliary tract cancer. Response rate was observed at 41.7%, median progression-free survival 8.6 months, and median overall survival 15.1 months. So if our patients are lucky, have the KRAS G12C mutation, we should definitely try adagrasib. And lastly, we're going to go over two mutation that is very rare. One is NTRK, one is RET. It's really uncommon, less than 1%, but we do have tumor-agnostic indication for these medication. So one is entrectinib, which is oral TKI that targets multiple targets, TRK, ROS1, and ALK. In a pool analysis of 3 phase 1-2 studies, examined this medication, a total of 54 patients were treated with entrectinib, and only one had cholangiocarcinoma. This is the robust data that we have. And this patient, we can see here, achieved a partial response with progression-free survival of 12 months. So that's pretty good, keeping disease at bay for a year. And the other one is larotrectinib, which is also a kinase inhibitor targeting TRK. There's a study that was recently published. They're looking at larotrectinib in patients with TRK fusion positive GI cancer. Total of 44 patients, 4 of them had cholangiocarcinoma. For the non-colorectal cancer cohort, including 4 with cholangiocarcinoma, they observed a response rate of 6%, stable disease 44%, progressive disease in 22%, median progression-free survival 4 months, and median overall survival 9 months. So entrectinib and larotrectinib, these are 2 medications that we have for patients with NTRK mutated biliary tract cancer. And the last one was RET. It's very uncommon, less than 1%, but my colleague, Dr. Suma Sadi, just tested me 2 weeks ago saying that she is seeing a new cholangiocarcinoma patient, and the patient has a RET mutation. What should she do? So definitely it happens. We should check that. We also have 2 drugs, has a tumor-agnostic indication. One is prasitinib. It's a TKI that targets the RET kinase. In the phase 1-2 ARROW study, they treated a total of 23 patients in the efficacy group. 3 had cholangiocarcinoma. For all patients, response rate 57%, disease control rate 83%, progression-free survival 7 months, and overall survival 14 months. We can see these 3 cholangio patients that I highlighted out. This one The one on the bottom was on it for maybe 5 months or so, not very long. This one on it for 11 months, almost a year. And this one is on it for almost 2 years. So that is pretty good for this patient. And the other drug is serpicatinib. It's also an oral TKI that targets the RET kinase. In the phase 1/2 Libretto study, they treated a total of 45 patients, 2 had cholangiocarcinoma. For all patient response rate 44%, disease control rate 77%, and median progression-free survival 13 months. So I don't know which one Dr. Sumasadi picked, but I think we definitely fully support the use of target therapy with a RET kinase inhibitor if the patient had the RET mutation. And lastly, I really want to focus and talk about the challenges of targeted therapy when we as providers are seeing and treating our patients. For me, it's really the resistance. If you think about all the data that we talked about, especially say for HER2, FGFR2, BRAF mutation, we don't really worry about the response rate. The response rate is so high. Disease control rate is almost 90, 96, 95%. We don't worry about we are having a good response. But in my personal experience, although they have a very good response in the beginning, very soon, they start, like within 2 or 3 months, we see the tumor markers start coming up, the cancer start growing. So that's my biggest problem when treating my patients with targeted therapy in cholangiocarcinoma. It's the very quick development of resistance. So this is a study that I found that is very interesting, that it looked at 77 patients treated with FGFR inhibitors for cholangiocarcinoma. They see that for these 77 patients, the overall response rate was 44%, disease control rate was 70%, so 30% of the patients actually progressed despite that they have an FGFR fusion. And the median progression-free survival was at 8.3 months. And they actually do a lot of the sequencing, DNA testing in patients like before and after progression. And in those after progression, they check the cell-free DNA, so they do have blood tests to look at the DNA. They found out that 65% of them actually had acquired resistance, actually have FGFR2 kinase domain mutations that make the patients, the tumor, not sensitive to the FGFR2 to the FGFR inhibitor. So that makes sense. And compared to patients with intrinsic resistance that they don't respond to begin with, only 10% of them had a mutation in the FGFR2 kinase domain. And they also reported the RAS mutation appeared in 13% of patients, with 78% of them rising concurrently with FGFR2 kinase domain mutations. However, if you look at it, 65% of patients had a mutation in this kinase domain. It makes sense. They don't respond to the FGFR inhibitor anymore. But 35% of patients had no detectable FGFR2 kinase domain mutation at progression. Then why did they develop resistance? We still don't know. So they actually recommend systemic analysis of off-target genetic resistance mechanism is needed. And they also think that, like they say, non-genetic factors, metabolic, transcriptomic, epigenetic, in acquired resistance warrant further investigation. And also, if you look at it, 30% of patients supposed to be responding to FGFR inhibitor, but not responding at all, they feel that intrinsic resistance is also an issue. Take-home points, novel targeted therapies demonstrate very promising efficacy in patients with advanced biliary tract cancer. The big targets that we have so far, HER2, FGFR2, IDH1, BRAF, V600E, KRAS G12C, NTRK, RET. It really highlights testing is the most important thing. If we don't test, we never know that we can use these medications. To me, the most annoying problem for me right now is why did they develop resistance? Dynamics of molecular profile in patients on target therapy, how to delay the onset of resistance, and how to overcome intrinsic or acquired resistance is important. We know that for the phase 3 Breakwater study in BRAF mutated colorectal cancer, that we know that if we move BRAF target therapy to the front line and combine it with chemotherapy, adding chemotherapy can delay the onset of development of resistance to the BRAF targeted therapy. So I know that a lot of companies, they're actually trying to use the same strategy, like we discussed moving the target therapy to frontline, combine it with chemotherapy to see if we can delay the onset of development resistance and further improve people's survival. But I also do feel that when we're doing this target therapy in the frontline setting, there's a lot of obstacles, right? A lot of challenges for us, such as a lot of times we may not be able to robustly enroll patients just because it's not very common targets, and sometimes patients are not treated at our institution, so we don't know they actually have these targets that we can randomize randomized surgery trial. We just discussed 2 frontline FGFR2 trials. They stopped enrollment because they just could not get that many patients on the trial. And that really highlights enrolling in clinical trials is the most important thing for almost all patients. That's how we continue to move the field forward and benefit our patients. And I'm happy to take questions. Thank you.
Are you repeating NGS testing after you treat someone with a targeted therapy?
Yes, when they progress, I will. Like, especially I feel that GI cancer, say HER2 positive, definitely happen, like it's HER2 positive, we treat patients with anti-HER2, and then very quickly they develop sometimes mutation in HER2 that made them resistant to anti-HER2.
I have a question. So if you have biliary tract cancer with multiple targets, how do you choose? Because the numbers seem to be pretty similar in terms of response rate, progression-free survival, median overall survival. There was a range, but they all seem to kind of lie within a similar range. How do you choose which one, assuming that they're FDA approved?
I'm not that lucky that I have more than one mutation. Like a lot of times if they're HER2 positive, I don't really see the other mutations. I don't know if they're mutually exclusive, may or may not be, but usually if we're lucky, we get one mutation. Okay, thank you all so much for your time.
Okay, great talk. Thank you so much. Our next speaker is Dr. Victoria Chung. She's an assistant professor in the Department of Internal Medicine at UT Southwestern in Dallas. She specializes in hematology and medical oncology with a focus on GI cancers and neuroendocrine cancers. She earned her medical degree in Alabama. She completed a residency in internal medicine and received advanced training in hematology oncology at Ochsner Medical Center in New Orleans, where she served as chief fellow. She is certified by the American Board of Internal Medicine, and she joined UT Southwestern faculty in 2024. Please help me welcome Dr. Chung.
Thank you. As he said, I did both my residency and fellowship here in New Orleans at Ochsner, so I was really happy to be invited back and to come back to New Orleans. It's been about 1.5 years. Not a whole lot has changed as far as I can tell. There's still music in the streets. But anyways, thank you all for having me, and let's get started talking. I'm going to cover targeted treatments in colorectal cancer. Dr. Du taught me everything I know, so unintentionally, I kind of made the same exact talk as her, but in colorectal cancer. So we'll just see how that's a little bit different. I'm going to cover mostly the treatments that are targeted towards mutations that we find on NGS sequencing in colorectal cancer. So I'm not really going to be going through the first lines of treatment too much. But here's the NCCN guidelines for first-line treatment for advanced or metastatic colorectal cancer. I did put here in the red box, you can see that for BRAF V600E mutation positive, we do have encorafenib and cetuximab or panitumumab approved with FOLFOX in the guidelines. And then for second line, there's this whole area to the right here for biomarker-directed therapy. So I'll be going through all of these and talking about the trials that led to these approvals and what we expect from these treatments. First, to talk about the importance of biomarker testing and how much we need to make sure that we're doing that for our patients with colorectal cancer. About 20% of colorectal cancers are metastatic at diagnosis. It's the third most common cancer in both men and women, and it's the third or fourth most common cause of cancer-related death in men and women. The 5-year survival is about 15.6%, and we know that precision oncology improves outcomes in these patients. I found this study that was published just about 2 years ago that I thought was interesting. They collected data on 41,000 patients between 2010 and 2017. I recognize that was quite a bit of time ago, so things have changed. Only 28% of these patients actually got tested for KRAS, and only 43% were tested for MSI. The overall survival was improved for the patients that were tested, which does not surprise me. Patients treated in the community were less likely to have biomarker testing, and then also patients that were older, patients that had lower community education levels, rural residents, all of this was associated with lower odds of MSI and KRAS testing. I actually have a personal story for this. When I was a medical student rotating through my hematology and oncology rotation, this is about 2016, so that lets you know about when I graduated medical school. I saw a patient, she was somewhere around 45 years old, so very young, metastatic colon cancer. She was honestly in the process of dying. Her cancer had progressed really rapidly despite treatment, and she was going into liver failure. She was in terrible pain. What was really sad, though, was looking at her treatment history and seeing what had happened. She was being treated with FOLFOX, and I forget, it was either cetuximab or panitumumab, but she came to the oncologist that I was rotating with for a second opinion, and she had a KRAS mutation. And so that was just unfortunate to see that it wasn't being addressed. Actually, and real quick, I would like to give a shout out to two of the posters that I saw here that I think are really relevant to my talk. There was one by Dr. Abdullah that I would recommend everybody go see. It's a big purple poster. Those doctors are at LSU Shreveport. They found a high prevalence of POL mutant colorectal cancers in their Louisiana cohort, much higher than expected, and particularly in Black patients, which are often underrepresented in our studies. And another poster by Dr. Mudier, excuse me if I pronounced that wrong, at Tulane, looking specifically at MSI testing disparities and survival outcomes in Louisiana. And they found that only 65% of Louisiana patients being treated for colorectal cancer were tested for MSI status, which should be done for everybody. So still clearly a problem despite the fact that this data set is old. So at diagnosis, per NCCN guidelines, all patients with colorectal cancer should have their tumors tested for KRAS, NRAS, BRAF, MSI, HER2, and TRK, POL, and RET. There's many different companies that are offering NGS sequencing. Some places even have it in-house now. Something that can be pretty nice is some of these companies are also offering DPYD and UGT1A1 testing along with this next generation sequencing. So that's really handy for me. At UT Southwestern, we are still working on getting in-house DPYD. So for me, this can be a really rapid way for me to get my answers about what genomic mutations these patients have, and then do I need to make dose reductions for their 5-FU, for their irinotecan, et cetera. And then for anybody that doesn't know, DPYD testing is now in the guidelines and is in the package insert for capecitabine. All right, so KRAS is probably our most relevant. Just like Dr. Du, I'm going to go in order from most prevalent to least prevalent. KRAS is found in about 30 to 40% of patients with colorectal cancer. It's involved in this pathway you can see here. When it's active, it initiates downstream signaling and it promotes cellular proliferation. I won't bore everybody with all the details. Mutations in the KRAS gene can stabilize the KRAS protein into its active state and therefore being constitutively active and activating cellular proliferation. Anyone that has a RAS mutation should not be treated with an anti-EGFR therapy, as in my personal story, so that's important to be checking for. KRAS inhibitors and degraders are also a really interesting target in a lot of clinical trials. I know a lot of people are very excited about that. Unfortunately, KRAS comes in many different flavors, and some of these are more druggable than others. KRAS G12C is only found in about 3 to 4 patients with colorectal cancer, but for this we have approved drugs. You can use adagrasib and sotorasib to treat this mutation. You can also combine them with an anti-EGFR antibody to mitigate the EGFR reactivation that can happen when you're drugging the KRAS G12C. So there's 2 different studies just to be aware of. The CRYSTAL-1 trial led to the approval of adagrasib plus cetuximab, and CodeBreak 300 led to the approval of sotorasib plus panitumumab. Other KRAS strategies, there's so much interest in this field, and we have clinical trials here at UT Southwestern. I'm sure y'all do here in New Orleans as well, looking at pan-KRAS inhibitors, SOS1 inhibitors, KRAS G12D selective inhibitors and degraders, and then anti-RAS vaccines. And since this is so common in colon cancer, but also pancreatic cancer, it's definitely a very big area of interest. BRAF V600E is the new, oh, not so new, but very exciting area right now in colorectal cancer. So this is found in about 8 to 12% of metastatic colorectal cancer. This does lead to a poorer prognosis and lower responses to chemotherapy than BRAF wild-type disease. The BEACON trial established encorafenib and cetuximab as a viable second-line option. Encorafenib is a small molecule BRAF inhibitor, and then cetuximab, the EGFR inhibitor, helps to overcome BRAF reactivation. This was moved to the first line with the Breakwater trial by combining it with FOLFOX, as Dr. Du mentioned earlier. So here's the Breakwater trial. I think this is a really beautiful overall survival curve. You see the red line here is a combination of encorafenib plus cetuximab and FOLFOX, versus the yellow line is just encorafenib and cetuximab, which was previously approved in second line. And then blue is standard of care. And in this study, it truly was standard of care. It was FOLFOX or CAPOX or FOLFOXIRI plus or minus bevacizumab. We got an updated analysis of the Breakwater trial just a couple months ago at ASCO GI, basically proving that you can also combine this with FOLFIRI. That's really helpful for when we're seeing patients that already have some underlying neuropathy, or for some reason you really don't feel comfortable giving them oxaliplatin. This is also a reasonable first-line option. Right, next up is HER2. HER2 is found in about 3 to 5% of metastatic colorectal cancer, so not terribly common. A little bit more common if they're RAS wild type, up to 14%, depending on what study you look at. If someone has a HER2 mutation and then they're BRAF wild type, you can give them trastuzumab plus pertuzumab, lapatinib, or tucatinib in second line. And if they're HER2 3+, you can give them trastuzumab deruxtecan in the second line or later. Trastuzumab deruxtecan also notably still has activity in a lot of patients after they've already gotten a HER2-directed therapy. So the Mountaineer trial was a global phase 2 trial which enrolled patients with chemotherapy refractory HER2-positive RAS wild-type metastatic colorectal cancer. It gave these patients tucatinib plus trastuzumab with a median progression-free survival of 8 months, overall survival of almost 2 years, and a duration of response of 15 months. There's also similar studies, the Heracles A study, which combined lapatinib and trastuzumab, and then the MyPathway Basket study combined pertuzumab and trastuzumab. Here is the waterfall plot for the Mountaineer final analysis. You can see, so the blue is partial response, and then green is complete response, so quite a few big responses in these tumors. Mountaineer 3 is an ongoing clinical trial looking at using chemotherapy plus tucatinib and trastuzumab up in the front line. Again, a lot of people looking at bringing these targeted agents into the front line in combination with chemotherapy. Destiny CRC01 was a multi-center open-label phase 2 trial which gave patients trastuzumab deruxtecan in patients with HER2-positive metastatic colorectal cancer that had progressed after at least 2 lines of therapy. And notably, it allowed for patients that had previously gotten HER2-directed therapy. It's a really great time to be trastuzumab deruxtecan, as we know with the success in breast cancer. It's an antibody-drug conjugate, and it's an anti-HER2 monoclonal antibody, which is linked to a topoisomerase inhibitor payload. As Dr. Du mentioned in her talk, there's also this possibility of a bystander effect where it can kill nearby cells that don't have the HER2 antibody. Here's a waterfall plot for the Destiny CRC01 study. Again, beautiful waterfall plot, lots of response here. The orange little carrots that you see on some of these, those are all patients that had previously been treated with HER2-directed therapies. So you see even a complete response in one patient who had previously been treated with a HER2-directed therapy. NTRK fusions are very, very rare in colorectal cancer. I have had one in my 2 years as an attending physician, though, so you'll still see them. About 0.35% of metastatic colorectal cancers. It's only present in RAS-RAF wild-type colorectal cancers. And just of note, these inhibitors are only effective for NTRK fusions and not mutations, and that can be really easy to overlook. Also important to know that the IHC test for NTRK can be a false positive. I think it was in up to 20% of cases, so it's really important to be confirming these with an NGS study. I'm going to be honest, I've never ordered an NTRK IHC anyways. With the wide availability of NGS sequencing, I just do that. All right, NTRK inhibitors, there are 3 that we have available: larotrectinib, entrectinib, and repotrectinib. I'm not going to spend a whole lot of time on these studies since Dr. Du actually already went over them. But NAVIGATE was the study that led to the approval of larotrectinib with an overall response rate of 25% in the colorectal cancer cohort. Entrectinib was approved in an analysis of 3 separate phase 1 and 2 studies. Overall response rate in the whole population is 57%, and then colorectal cancer patients, about a quarter of those patients had a response. The TRIDENT-1 trial led to the approval of repotrectinib. These patients could have been pre-treated with larotrectinib or entrectinib, so that's important to note. PFS of 56% at 12 months in the TKI naive patients, and then 22% in those that had been pre-treated. All right, next up is the POL mutation, which, as we saw in one of our posters here, is maybe more prevalent in Louisiana, maybe more prevalent in the Black population than we had thought previously. POL mutations result in a loss of proofreading function. They can be found in proofreading-associated polyposis when it's germline. Somatic mutations are present in about 1% to 2% of colorectal cancers. They can cause a hypermutated phenotype, and so if you have a patient that has a POL1 mutation with the hypermutated phenotype, they should be treated as if they were an MSI-high colorectal cancer. So these have a very favorable prognosis. It's really important not to miss this one. RET fusions, very uncommon in colorectal cancer, less than 1%. The fusions activate the RET pathway. It's more prevalent in older patients and in right-sided tumors, and it has a worse prognosis. Per the Libretto trial, you can treat these patients with selpercatinib with an overall response rate of about 20% in the colorectal subgroup of the study. We have other targets under investigation: the PIK3 pathway, PIK3 mutations, and also MET. And another targeted treatment that I'm really looking forward to is zanzalintinib. Now, this isn't approved yet, but the Stellar 303 trial compared patients with chemo-refractory colorectal cancer and randomized them to get zanzalintinib, which is a multi-target TKI, plus atezolizumab versus regorafenib in refractory colorectal cancer. So, immunotherapy historically has not really worked very well in colorectal cancers, but the thought is that zanzalintinib targets these TAM family receptors and maybe allows for less of this negative immune regulation and allows them to be more sensitive to immunotherapy, so that's hence why they combine it with atezolizumab. This is the overall survival curve. As you can see, it outperformed regorafenib. Anybody who's prescribed regorafenib is very excited to give something before regorafenib. And this is under FDA review right now. So we talked about repeat testing earlier. Significant molecular changes are not really all that likely after just cytotoxic chemotherapy, but if you're giving somebody targeted treatments, the mutational profile can change. So I would definitely consider retesting. And I think that this is a really interesting graphic that I found. Looking at the y-axis is median progression-free survival, and the x-axis is objective response rate. The size of the circle represents how many of the patients were evaluated. As you can see, the immunotherapies are the sort of the pale blue circles. I mean, they have a great objective response rate and progression-free survival. I think none of us are terribly surprised by that, but it shows how important it is to make sure that we're identifying MSI-high tumors when they're present. You can also see the HER2 targeted drugs do quite well. Those are the dark blue ones. They're definitely on the higher end for objective response rate. And then EGFR and BRAF mutation or targeting drugs are in the middle with orange. NTRK, I wish, did a little bit better, but it's still really important to find those when they exist because it's another good treatment option to have in the bag. So take-home points is I said an NGS testing for all patients at the diagnosis of metastatic colorectal cancer. To be honest, I think we could even scratch out metastatic colorectal cancer. I think we, especially with the approval of using daily aspirin after treatment for colorectal cancers that have PIK3 mutations. I think you can justify in sending it in pretty much anybody. The rare mutations are rare. You know, we keep saying, oh, it's less than 1% or it's less than 2%, but that compounds. When we're seeing all of these patients, you're going to find these mutations, and you'll never find them if you don't look for them. Consider clinical trial enrollment where available. We're lucky to, or everyone here is lucky to live near some really great cancer centers that have lots of ongoing clinical trials. Consider retesting after targeted treatments. And reevaluate the treatment algorithm at time of progression. New treatments are coming along every single day. I only graduated fellowship a couple years ago, and I'm still having to learn new treatments every single day. I didn't put that in there, but thank you. Yes.
Like at UT Dallas, how are you doing the MSI, MMR testing? Is it all in-house IgG or MMR?
Yeah, so at UT Southwestern, MMR is all done in-house. That is, I would say about 95% of the time is reflexed, and so that I already have that by the time I see the patient. It's in-house IHC.
That's what I'm thinking. We're doing the same thing like MMR testing for all colorectal cancer diagnosed at Ochsner. But if we think that there may be, I don't know, like 2% to 5% of patients with polymutation, then we're potentially, like, unless there is that disease, of course we do NGS and find out there's MSI. But if we don't have metastatic disease, then anywhere from stage 1 to stage 3, we are not picking that up, right? I think right now, because like we need to consider, do they need an aspirin because of P3C mutation, we are sending all resected to NGS testing. We may be able to pick up more outside, but I wonder if we miss the 5% of patients, like they actually did not think stage 2, they actually did not think adjuvant treatment because they have, say, MSI high, but because of polymutation.
Yeah, I think that's a good point. We've at Park, so I work at UT Southwestern, but I also cover Parkland Hospital, which is kind of UT and kind of not. We've been working with the surgeons to actually have them send NGS testing at diagnosis for all colorectal cancer patients before they refer them to us, which is in process, but I'm hoping that'll help.
That's a great project.
Yeah.
That was my question, was who do you prefer sending it? Should we send it diagnosis? I mean, you said, you mentioned retesting it, you know, if they have progression or, yeah, so who do you recommend?
So I would never be mad at a surgeon who sent a patient with stage 2 or 3 colorectal cancer who already had NGS, DPYD, and UGT1A1 testing to my doorstep. That would make me very happy. If I have all that information.
Because it expedites things.
Exactly. I can get somebody started on the treatment that they need to be on.
Your conversation is now more pointed because you don't have to say, I think I'm going to do this, but I'm going to get your NGS and I'm going to see what we're going to do. It's already done.
Exactly. And I don't know how it is with everyone else, but for me, I have my long block with a patient the very first time I see them. And for subsequent visits, that's a much shorter visit time that I have to spend with them. I'd much rather have that long conversation about how I expect treatment to go, all of the drugs you're getting up front.
I think in the past, like, we only send for stage 4, right? Because within stage 4, like, we need to send it, insurance should cover it. But for non-metastatic stage 1 through stage 3, we don't send it, like, who's going to pay for that, right? But right now, we have the, like, over the past 1 year, we know that they have PIK3C mutation, resected colorectal cancer, we need to give them aspirin. So I think right now, the initiative should be, we should send all colorectal cancer origins.
But to your point, insurance will cover it?
I have not had a problem with it yet, but
Even in the 1 through 3s?
not yet.
A lot
But
of times they will offer like patient
And we're
assistance.
talking about colon cancer or biliary tract cancer?
Colon.
I think with the recommendation for aspirin with PIK3 mutations, you don't know unless you look, so you have to send
And
it.
there's no commercial PIK3CA.
Yeah.
You just have to go through NGS.
Okay.
Any questions? All right, well, thank you all. All right, we're going to move to the final portion of this session that is going to be a panel discussion. And you're going to lead us off? All right, wonderful. Right.
PowerPoint.
Can we sit up here? There should be a PowerPoint.
There we go.
All right, so my name is Randy Cannell. I am a clinical nurse specialist at Ochsner, and it is my pleasure to be up here to pick the brain of these wonderful physicians. So we are just going to go through a couple little cases and see what they think about this and what they would do at their institutions. So our first case is a 64-year-old male that was diagnosed with alcoholic cirrhosis that had portal hypertension. He's still drinking, but no other comorbidities. His total bilirubin is a 1.1, and he's a Child-Pugh A6. His AFP was 31, and he's had no prior HCC screening until the MRI was ordered by his hepatologist. That MRI showed a 4.1 by 3.9 centimeter, LRADS 5 lesion in the right lobe of his liver, no evidence of vascular invasion, but he had cirrhosis with splenomegaly. And this is what those scans were looking like. So as a surgeon, Dr. Lyons, what are you looking at on here?
Okay. So this looks like T2 over here. That looks like T1 post over here. And he's got a lesion in the right liver. Pencil somewhere.
Do you want the
I have
pointer?
it. Yeah, let me have some pointer, thanks. Yeah, so things that I see, I think that's a little bit of fluid, maybe. So he's probably got some ascites. The spleen is massive, so he's clearly got portal hypertension. I don't remember what his platelet count was. But this is the index lesion right here that we're talking about. Right liver, I think that's portal vein right there, portal vein right there. So if you're asking me if it's resectable, probably so, but I don't know if his liver's going to tolerate it. Probably not, given all of this stuff. So but that's what we're dealing with. So what do you think?
Usually, if patients have like splenomegaly, portal hypertension, and we usually, I think our surgeons would prefer having non-surgical approach, and for us, we'll probably do Y90, and that depends on whether the patient is a candidate for transplant or not. He's actively drinking, so I'm not sure about it. If not, if he's a candidate for transplant, then we'll probably Y90 bridge to transplant. If not, then probably.
Yeah, I mean, I agree. I think that the best option for this gentleman with a 5 centimeter, right? 4.9. Yeah, I mean, he again meets transplant criteria other than the fact that he's, drinking. So if we can help him with his alcohol consumption, bridge into transplantation, that's his best outcome. That's his best opportunity right there. That makes me concerned. I agree with you. I wouldn't be enthusiastic about doing a major hepatectomy. I think that it's central enough that it would require a major hepatectomy, which would be very morbid in this individual. So yeah, I think if you could get him to transplant, that'd be ideal. What bridge you use is a whole other conversation. Typically, you use Y90.
Usually, we use Y90.
I see. What do you use? Do you know? Is this something that you have experience with? I know you're more right with those.
Yeah, I'm not sure, because I don't treat any of the HCC VUT. That's all kind of actually a separate little department.
Yeah.
So I'm not really sure about HCC first.
Yeah.
But I definitely would bring up for transplant evaluation despite his ongoing drinking in order to don't ask.
Yeah. I think Y90 is interesting because Y90 it has some persistent effects in the liver, and so I think that the advantage to Y90 is that it's outpatient and it's very well tolerated, but the downside is is the potential for radiation effects in other organs. So if you or even in the liver, so if he's borderline. Do we have his child? He was pretty compensated, wasn't he? Yeah. Okay. Yeah, his child's Pugh A6. Okay. So then he ought to be a candidate for Y90. I think whether you do Y90 or whether you do percutaneous ablation, I think would be another option. That might be what we do.
Yeah, 4.1 may be a little bit large.
It is. Yeah. You're right.
What about something like TACE instead of Y90?
Well, they have a phase 2 trace study directly compare head-to-head TACE versus CARE Y90, and it clearly showed that Y90 has way much better response rate, better proportion of patient level, better response.
As a bridge to transplantation.
Okay. All right, so we went over those treatment options that y'all are thinking of. Now, what if there was portal vein invasion? Would you change anything about that?
Well, I think portal vein invasion would make it not a transplant candidate, so I think you have to consider, another alternative liver therapy. So, again, I think combination percutaneous ablation, SBRT potentially is big for that. That might be an option for him. I think, we're talking about transarterial treatment would be an option for him. It's challenging because those modalities have been compared head to head, to know which one's preferable. But in general, I think the comment was made that this is probably a little bit big for percutaneous ablation.
I think DP3 will bump the patient also from a BCLC stage 8, potentially curable HCC, to a BCLC stage C, so advanced stage, not curable HCC. So our goal is really like, as a talent, trying to prolong people's life. My IR colleague told me that before we had immunotherapy for HCC, actually 190 works very well for portal vein, for both for portal vein invasion. And actually, if it's just the solid tumor, a lot of time we will actually combine 190 with systemic immunotherapy, and we have seen good response in our patients.
What's your preferred first line for metastatic or carcinoma?
I think it depends on the
Right now.
comorbidities.
Yeah.
If people have a lot of portal hypertension and worry about esophagitis, then that may not be the ideal. I would say stride is probably the easiest, so that patient has a lot of comorbidities, I use stride. I also have patients who are young and fit, and they're willing to put up the side effect, and maybe which has the highest response rate.
The stride regimen is nice just because it's so many fewer users, right?
And it's easy.
Yeah.
So you would treat this gentleman as if he was metastatic.
Right, for BCLC stage C, because it's not curative. So usually, if you really go by the BCLC category, the algorithm, we should use systemic therapy. Right? We know that solitary portal vein invasion might not be treated pretty well, so that's why we come out.
Yeah.
We had a couple of home run patients in remission for years.
Okay. Now, let's say, depending on their treatment response, would you ever discuss with them that they could potentially be downstaged and maybe go to transplant at that time? Would you ever talk to them about that?
Yeah, I think if it's liver-only disease, and say after 2 or 3 years of treatment, complete response, no evidence of disease on the scan, our transplant surgeon actually are willing to consider patient for transplant.
Maybe stop drinking in the meantime.
And then stop drinking.
Yes, get them to that cessation program. All right, so moving on to our second case. This is a 51-year-old female that presented with 3 days of dark urine, itching, and yellowing of her eyes. She has no significant past medical history and no known family history of cancer. She was taken for an ERCP, and they put in a metal stent. And her EUS had a 1.8 centimeter mass at the head of her pancreas. The fine needle biopsy confirmed the adenocarcinoma, and it was microsatellite stable. So her CT showed no clear mass and no vascular involvement. There was no evidence of metastatic disease. And her CA19-9 after that decompression was still 78. So the first question here is, how would you classify the staging of this patient?
Well, it's resectable.
All right.
So we classify periambular lesions as resectable, borderline, or locally advanced. And go back for a second. Based on this single cut, it seems to be resectable, and the CT doesn't show a clear mass, and the EUS implied that it was resectable. So I think that's how I would classify it.
All right. So what is the typical treatment approach? Would you bring them to surgery first, or would you do a perioperative therapy approach?
Yeah, that's the question, isn't it? If this is a pancreatic primary, is what we think this is.
It's pancreatic.
Yeah, but I don't know if it's biliary tract. It could be just a biliary tract. It wasn't made clear, it just said adenocarcinoma. But assuming that this is a pancreatic primary, my preference is to give them neoadjuvant. There's not data to support it in the resectable setting. We have a few randomized trials that have looked at neoadjuvant chemotherapy, and it does appear to have action in locally advanced, but not in the resectable is your, how many regimens, how many cycles do you typically?
Typically, it'd be in for 6 months before and after combined, and so exactly when their surgery is a little bit up to the surgeon, and so I usually let them direct about. Typically, we're doing 4 months before surgery and then 2 months of chemotherapy after surgery. But sometimes that changes just with things that happen with the patient.
Yeah, it's interesting, it's sort of dynamic, you know,
Yeah.
and I don't know if there's an industry standard, I think it's institution specific and patient specific. And you've got some people that can tolerate it and get all their chemotherapy up front. I mean, their oncologist call me and says, John, he's doing great, I'm gonna give him a few more cycles, and I said, go for it. And then other ones who they give 2 cycles to, and they say, you can't do this, you have to take it. So, and then some people follow the 19-9.
Yeah, our surgeons tend to follow the 1990 to see when it's dropping. It's also, it can be so hard to get people back on chemo after.
After surgery.
Yeah.
Right, that's why I mean, if you can give it all from time, very good. And it's a biomarker, right? I mean, if you have a good path response, that's good knowledge. Yeah, that's good knowledge. Yeah.
All right. So the next question for this case is, how do you talk to your patients about germline testing? Are you sending them for germline testing, or are you just doing things like NGS and molecular profiling?
I do it all. I send all of my patients to see the genetic counselor, and I also do NGS testing on every patient with pancreatic cancer. It's not necessarily changing what I'm doing right now, but we know that most of these patients are going to have recurrence, so I'd like to be prepared for it. The way I discuss germline testing with them is I let them know that it is a weighted recommendation.
Yes,
And
it's
not
part of
just I say that I send all of my patients with pancreatic cancer for genetic testing. Most likely we will not find anything, but if we do, that can be really important for their field.
Not that sending hereditary testing is so easy, I just send it myself, as long as the patient's okay with that. And then I also do both like blood NGS, and once we resect it, we do the tissue NGS as well. I think for pancreatic cancer, unless it's wild metastatic disease, I think that the challenge is a lot of time we cannot really get the DNA testing result. If it's not in of itself in the tissue, they cannot really report anything. And when you biopsy, it's like 2 cells, we cannot really get a lot of information.
Also, just a note about germline testing is pancreatic cancer should be approved, that shouldn't be a problem, but my genetic counselors at UT Southwestern have really encouraged me to send anybody to them because the out-of-pocket cost is really not that great, and those people are willing to pay for it just for peace of mind, even if it's not necessarily recommended for their cancer by guidelines.
For germline testing.
You know, bringing it back to the NGS, I think both of you touched on how important this is just because of all of those mutations that we don't want to miss. Now, what if her scan looked like this?
Case 2.5. Well, so in this case, you know, this is, I guess that's a hepatic artery. And yes, I'm not sure that's SMA or hepatic artery, but it's a major blood vessel that's got 180 degrees of abutment, and this has got 360 degrees of encasement. So, you know, this changes the resectability, so it's no longer what we would say resectable, it's now locally advanced. And it's not known if this will ever become resectable, but so definitely we would want neoadjuvant chemotherapy, probably radiation as well on the front end, and then consideration of surgery if we get a nice response.
Yeah, we would usually locally advance. I was never fortunate enough to get any patient into resection, so usually we consider it not curable and we do palliative chemo. I do have patients responded extremely well to chemotherapy that after they've been chemo for a long, long time. We're like, okay, we can get consolidative chemo radiation, but it's not curative either. It just hopefully after chemo radiation, people can have a chemo holiday for a little while. And eventually, most of the time, cancer will come back somewhere else, like peritoneum, liver.
Now, would this change your management of what you're choosing as far as chemotherapy regimens?
I think that we'll go by the same principle as we treat metastatic stage 4 pancreatic cancer. Fit patient, probably for peritoneal FOLFOX, not really fit patient, generalizing whenever we have a clinical trial.
I think another interesting point to bring up with locally advanced pancreatic cancer is you can also now use tumor-treated fields. So, you know, the stickers you stick on your abdomen, they have pretty good data for reducing pain
Are y'all using that at UT Southwestern?
We just started.
And the patients tolerate it pretty well?
TBD.
All right. Our last patient to talk about is a 57-year-old female that was recently diagnosed with adenocarcinoma for sigmoid colon. Her ECOG is 0, and she's completely asymptomatic from her primary tumor. Her CT showed sigmoid colon wall thickening. She has bilobar liver mets and no evidence of any other peritoneal lung or extrahepatic disease. Her CEA is 260, and on her NGS, she was microsatellite stable with an APC and an FBXW7 mutation. She's RAS-RAF wild type, HER2 negative with a TMB of 3. And then here are her scans. Any thoughts looking at those briefly?
There's a lot of disease. I didn't count them, probably 20, at least 1, 2, 3, 4, 5, 6. That's probably 6 or 7 right there. And, yeah, many. It doesn't fall within resection at this time. So again, I would be calling the medical oncologist to say, let's start systemic therapy first.
Yep. So how would you approach the first-line therapy for these patients?
I think our best data, of course, a lot of times for patients RAS wild type, from I would probably combine FOLFOX with anti-EGFR. If we really want to be extremely aggressive, sometimes we have data for combining FOLFIRINOX plus an anti-EGFR. It's just like whether patients willing to undergo those sorts of things.
And I think if you have a decent response, and maybe a response in the CEA, and you have some radiographic response, I don't think it would be unreasonable to consider carotid artery infusion in this person. But I think you treat them systemically first. And I think it's interesting. I think that's very institution specific, and I'm not sure how you guys would tackle that at UT. At Memorial, it would be pump up front, but at many other institutions, it would be systemic and then potentially pump up.
Yeah, all of the surgical oncologists at UT Southwestern trained at Memorial Sloan Kettering, so they are very, very pro HAI pump. To be determined if that's actually
Right. I mean, I did as well, so I know all those guys, and yes, so that's why I can speak that. Yeah, I think that would be the practice, but I don't know that that would be the way that these don't, Duke or some of the other big centers.
I think we'll probably start with systemic chemo if they have a good response, and probably take out the primary and put it on.
I've done that a few times. Unfortunately, I've also had patients that then relapse systemic disease, and so to do that. It's an option. Yeah.
Yeah, that's right. And I think intuitively it makes sense to put more systemic first for those reasons that we're talking about. Because there's such high risk for distant relapse or distant progression.
Okay. And then do y'all think there would ever be a role for a liver transplant? Let's say the primary comes out because they had a good response on systemic, their CEA becomes less than 80, and they've been responding to the treatment for about 6 to 12 months. Do you think they would ever be a candidate?
Yeah, I think our transplant surgery will consider liver transplant. Right. Not curative, but improve survival in highly super situation.
I don't know is the answer. We're not a transplant center. I don't have any personal experience transplanting, colorectal cancer. What I know about it is that I think that most, and I don't know if you guys have a protocol, but I think, it requires sort of a progression-free interval that's pretty long, at least a year, maybe 2 years of responsive disease, and at least stable disease before we consider transplant. So I don't know that 6 months is long enough, especially with a CEA of 260 or whatever. We have to see some significant biochemical response there, in my opinion, before I would refer somebody for consideration transplantation. Do you know if the pump, does that affect their eligibility for transplant? I don't think it should. Yeah, I don't think it should. Do you have a protocol for liver transplant?
As far as I know, our transplant team actually only requires 6 months of disease stability, but I share your reservations that that seems like a very short
Yeah.
For transplant. It's a huge undertaking for the patient. And
And also a very valuable work.
Yeah, for sure. Yeah, for sure. You know, and the concern is, I mean, you know, the theory is you can transplant them and their recurrence in the graft is low enough that they will have recurrence potentially in other disorders, potentially the lung. But even when you resect the lung, it still offers them much longer survival than they would have after you had done the transplant in the first place. So very few people have been cured, which you may be moving the survival needle longer and doing it. So I think that's the rationale. You gotta be real careful about patient selection. It's a big surgery. It's a lot of resources for somebody.
Again, biology is key.
That's
You
right.
have to transplant the cancer through biology.
That's correct. Yeah, and you're just starting off. You have to see a real good response. You have to see some real behavioral lesions before you jump in. You know, and then, you know, from a resection standpoint, the patient's not resecting well in the gate, but the goal for the pump would be to convert them to resectability. That might be a big ask in somebody with that level of disease. But I think, again, if you had enough responsive disease for enough of a period of time and resectable disease, it wouldn't be off the table. I think either resection or transplantation could be part of the conversation in the right patient. You know? And it might be that it would be a two-stage deal where you did a portal vein embolization on the affected side, ablation on the contralateral side, and then coming back and doing the resection. You know, so there are a number of ways. There's not one standard. This is very, very individualized treatment based on biology selection, all things. You know.
All right, well, that is all. I thank all of y'all for your thoughts and experience. So we can get y'all out of here a little early.
Well, that's where we're at. Thank you all.
I saw Andy. I know, the first she needs to fly back. Yeah.